Hello, my dear friends. Dr. Dhawan here, your ENT faculty. Good evening, everyone. Good evening. Welcome to this session. We'll wait for a couple of seconds and then we start. Okay. Welcome to the session of INICT, rank deciding questions. Just a minute and we start. Please do inform your friends also that the session is live now. Yeah. Sure. So good evening once again, guys. Welcome to the session of Doctorals rank deciding question series for upcoming INICT. Definitely usable NEET PG also. So I hope you have taken this test. I hope you're done well. And let's, on the basis of this, like a collection of questions, discuss a couple of points which are relevant for the INICT and of course, the NEET PG exam also. I'll request everyone to inform your friends also who can be benefited from this session. Okay. I hope everyone is doing well, and I hope everyone is preparing well because INICTs, we do understand. People say it's like highly competitive. Yes, every exam is competitive, but number of seats are high in INICT, and like you can give your best shot actually, definitely. So let me add a couple of preparatory points to your ENT segment of the preparation. The first question, without wasting any time, they are very fond of the anatomical correlation with the clinical subjects, actually, which the following structure does not drain into the area marked with a red arrow on the lateral wall of the nose. My dear friends, this actually somehow is a favorite specimen which INSCT would be asking in ENT. So this is lateral wall of nose, my dear friends. And let me mark the structure. This is your inferior turbinate. The IT is inferior turbinate. This MT is middle turbinate and ST is superior turbinate. What are turbinates? They are projection on the lateral wall of the nose. And of course, you know it that this is inferior meatus. What open into inferior meatus is? Answer is nasolacrimal duct open into inferior meatus. Now, it will be a rapid fire round. Please be fully mentally available. I want to make each minute of some use to your preparation. So it won't be really rapid fire. Keep revising with me. So what drains inferior meatus? Nasolacrimal duct. And what is the direction of nasolacrimal duct? Ophthalmology question. It is downward, backward, laterally. What is the direction of nasolacrimal duct? NEET PG question. Downward, backward, laterally. How to remember? Downward, backward, laterally. DBL, double. DBL, double. Downward, backward, laterally. If nasolacrimal duct is blocked, what is the name of disease? What is the name of disease? What is the answer? Everybody try to write in the chat box also. What is the answer? The answer is what? Yes, chronic dacryocystitis. What is the name of surgery? DCR surgery. And the DCR surgery, we do make a hole in the middle meatus. So DCR opening is made in the middle. Dacryocystoreinostomy, that opening is made in the middle meatus, my dear friends. Now, everyone, the middle turbinate, and this is, my dear friend, is the middle meatus. Space below the middle turbinate, middle meatus. What open into middle meatus? Very important question. Maxillary sinus, frontal sinus, anterior ethmoid open into the middle meatus. Now, what is this, bache? This is superior meatus. Superior meatus. Below superior turbinate, superior meatus. And what open into superior meatus is, of course, posterior ethmoid air cell. So, posterior ethmoid air cell open into the superior meatus. And most importantly, this is the sphenoethmoidal recess, INSTT PYQ. This star is the sphenoid sinus. Star is the sphenoid sinus. And sphenoid sinus is very much, posterior most sinus, right behind the orbit, and it drains into what? It drains into sphenoethmoidal recess. So superior meatus, we have posterior ethmoid air cells. The middle meatus, we have the maxillary, frontal, anterior ethmoid air cells. but the sphenoid, this S sphenoid drain to the sphenoethmoidal recess area, my dear friends. So this is the very important lateral, section, and you should keep in mind this thing, Vijay. Now, a couple of more questions about the visual questions. One is the cadaveric lateral wall section. Anytime you see the arrows on the side of the larynx, any guesses? Any guesses? Please be active in the live chat. PYQ of INICT, NEET PG also. Of course, it is what? Piriform sinus. Also called piriform fossa. NEET PG said piriform fossa, no problem. So piriform sinus, piriform fossa is the any arrow on the side of the larynx, this side, because there are two piriform sinuses, right side and left side. Right side and left side, very good. Everybody, please inform your friends also. Let everyone join, let everyone work. Let's revise ENT together. So any arrow on the side of larynx will be piriform sinus, piriform fossa, and it is plied by internal laryngeal nerve. Very famous question. The sensory nerve supply of piriform sinus is internal laryngeal nerve. And NEET PG question, INICT question, this is the main nerve to prevent aspiration. Which nerve prevents aspiration? Famous question, the person who has taken alcohol and he can aspirate, which nerve is accountable for preventing aspiration is internal laryngeal nerve. Internal laryngeal nerve. Okay. Now, again, one more visual question, very, very important. This is the hidden jewel still over there. Anytime you see a naked nerve traveling between the malleus and incus in the middle ear cavity, it is cauda tympani nerve. Guys, this yellow nerve is called tympani nerve. Anytime you see a naked nerve, wire-like nerve, without any bony canal, wire anywhere, even if they don't show malleus and incus, any hanging nerve traveling in the middle ear cavity from this side to that side is cauda tympani nerve. And cauda tympani nerve is a branch of which segment of facial nerve? Vertical segment or mastoid segment of facial nerve. And this is the taste sensation of anterior 2/3 of tongue. Okay. Guys, please understand that the posterior 1/3 of tongue, the taste sensation and the general sensation come from the glossopharyngeal nerve. But the anterior 2/3 of tongue, taste sensation comes from the cauda tympani nerve. Okay. Again, a very important anatomy question of INICT. Nobody can forget this picture. It's omega-shaped epiglottis, a favorite domain of INICT, NEET PG, both, and the diagnosis laryngomalacia. Let's have a quick review of laryngomalacia. What is the patient profile? It's a newborn baby. It's a congenital problem. It is weakness supraglottis. Child has inspiratory stridor since birth. Inspiratory stridor since birth. You know the answer. Inspiratory stridor since birth is laryngomalacia question. Since birth. The stridor is less in which position? Prone position. Stridor increases after crying and suckling of milk. After breastfeeding session, the stridor is higher. But most important thing is cry sound of baby is normal because vocal cords are normal. Laryngomalacia is a weakness of supraglottis, not of glottis. So chief complaint is inspiratory stridor. Supraglottic problem cause inspiratory stridor. Dr. Dhawan, which two conditions we have to mark inspiratory stridor as the answer? Number one, laryngomalacia. Number two, acute epiglottitis, which is the bacterial infection of supraglottis. Okay. Dr. Dhawan, in which case we have to mark biphasic stridor? Group. Acute laryngotracheobronchitis. The most affected area is subglottis, and subglottic problem cause the biphasic stridor. Do we need to, do intubation or tracheostomy in this patient? Not at all. You do endoscopy and you see beautiful omega-shaped epiglottis or folded epiglottis. This child has no hypoxia, no cyanosis. No hypoxia, no cyanosis. So treatment of choice is conservative treatment or wait and watch. Reassure the parents it is self-limiting condition. Self-limiting condition. My dear friends, I have something for you to remember. Everybody, please see. In which conditions in ENT, in which 4 MCQs in ENT, you have to write down treatment of choice, conservative treatment or wait and watch. In which 4 multiple choice question or clinical scenarios, you have to say the treatment is conservative. Number 1 is of course, laryngomalacia. Number 2, unilateral vocal cord palsy. Unilateral vocal cord palsy do not require any urgent intervention. Then CSF rhinorrhea. In CSF rhinorrhea, don't mark any aggressive surgery. Okay, treatment is conservative treatment with bed rest and antibiotic for 7 to 10 days. Okay, and 4th is traumatic perforation of tympanic membrane. Traumatic perforation of tympanic membrane. You have to prove the treatment is conservative treatment. So in 4 situations in ENT, you have to write the treatment of choice is conservative. One is laryngomalacia, other is unilateral vocal cord paralysis, CSF rhinorrhea, and traumatic perforation of tympanic membrane. Now, another visual question, favorite domain of INICT. If you ever see an ulcerative lesion on the nose skin or pinna skin, on the nose skin or pinna skin, the answer is basal cell carcinoma. If you ever see the ulcerative lesion on the skin of the external nose or the skin of the pinna, please do mark the answer as basal cell carcinoma or rodent ulcer. Rodent ulcer. Now, second question. Very, again, audiological domains, audio hearing aids, cochlear implant, and all. These are very favorite topic for the INICT. Which is following is a correct match regarding indication of given hearing devices. Now, yes, there are 5 devices given, and 5 indication you have to match very carefully. Now, number 1 is, of course, let's talk about BAHA. Now, bone-anchored hearing aid. Bone-anchored hearing aid, basically, in this hearing aid, what we do is, first of all, we put a titanium screw on the skull bone. And then we attach the hearing aid to this screw through an attachment called abutment. So 3 parts of BAHA are, number 1, titanium screw. Number 2, the hearing aid. And number 3, attachment is called abutment. What are the indication of BAHA? What are the indication of BAHA? Please see. Number 1 is anosmia. No pinna, anosmia or microtia. Anosmia or microtia. No pinna or small pinna. Number 2, very important, EAC atresia or EAC stenosis. The canal is not there or canal is very, very narrow. And 4th, EAC is wet. Chronic discharging ear. This picture, the chronic discharging ear, the pus will spoil the hearing aid in one go only. So in chronic discharging ear, in the wet ear, this wet ear, chronic discharging after surgery also, pus is coming, pus will spoil the normal hearing aid. So in this case, we have to go for the bone-anchored hearing aid. So what are the indications of BAHA? Number 1, anosmia. Number 2, microtia. Number 3, EAC atresia. Number 4, EAC stenosis. Number 5, chronic discharging ear or wet ear. And lastly, unilateral severe SNHL. In bilateral profound SNHL, we go for cochlear implant. In unilateral severe SNHL, we go for bone-anchored hearing aid. So in this case, please see, the bone-anchored hearing aid would be required for what? BAHA would be required for, of course, the chronic discharging ear. Number 2, cochlear implant. Let's do the cochlear implant, everybody. Cochlear implant, this one, very, very favorite topic again. Cochlear implant is something, an electrode or the receiver stimulator. This is the electrode or receiver stimulator we are putting right into the cochlea. Okay, it's a surgical part. This is a surgical part of the whole story. And cochlear implant electrode, the multi-channel electrodes are better than single-channel electrode. These are channels. These are channels. Okay, fine. So through which window we enter? Of course, we enter through the round window. This is the oval window. We put the electrode through the round window. Into which part of cochlea? Scala tympani of cochlea. Into which part of cochlea? Scala vestibuli, scala media, scala tympani. Into which part of cochlea? Scala tympani of cochlea. Okay. Now, this is the internal component of cochlear implant. After surgery, right over there, we do some X-ray also. Remember last time NEET PG question? This is the modified Stanford's view actually. Can you see this beautiful electrode over there? Please look at this one. I'll mark an arrow, a yellow arrow. You can see, tell me in the chat box, are you able to see these multi-channels over there? This is showing that cochlear implant has been placed properly. Okay. Now, fine. My dear friends, one more thing was shown in the question last time was, this is a real electrode. But if they show you, for example, this is a real electrode, my dear friend. This is a real electrode. But this is the neutral or earthing electrode. Or you can say this is the, this is not having, it just to create the earthing for the electrical transmission of the impulse over there. So this is the receiver stimulator or the electrode. And this is the earthing electrode or the neutral electrode over there. Okay, I hope you remember this question, everyone. Okay, do you remember this question of NEET PG last time? But please interact with me in the chat box and tell me did you remember that this was there? Okay, fine. Now, you can ask me, Rajiv, what is the best approach for putting cochlear implant electrode? Please see. This is again a very favorite domain. Please see over there. This is what the most commonly used surgical approach for cochlear implantation is, the transmastoid approach. First, you open the mastoid. This is the opening. You have made this is the cortical mastectomy done. And this window is called posterior tympanotomy window. This window is called posterior tympanotomy. This whole cavity is cortical mastoidectomy, transmastoid approach. So this whole gadda is called, this whole gadda, bache, this white gadda, this whole white gadda is called cortical mastectomy, and this window is called posterior tympanotomy. And where this window has been created, the answer is facial recess. My dear friend, possible question. Facial recess is surgical landmark for posterior tympanotomy. Facial recess, very good. Facial recess is the surgical landmark for posterior tympanotomy. Okay. Through this, you go through a round window and you put the electrode into the cochlea. Now, my dear friend, cochlear implant does sound stimulation or electrical stimulation of cochlear nerve ending. Anybody? Cochlear implant does sound stimulation or electrical stimulation of cochlear nerve ending? The correct answer is electrical stimulation. Electrical stimulation. Okay, fine. Okay, fine. Okay, now electrical stimulation. Yes. So, very famous question of NEET PG INI CET is prerequisite of cochlear implant surgery is normal 8 nerve. Normal 8 nerve. Okay. So, before you do the surgery, you must see MRI. If MRI shows normal 8 nerve, only then you go for the cochlear implant surgery. Okay, cochlear implant surgery. Now, another question. Posterior tympanotomy is the name of this window, and the surgical landmark for posterior tympanotomy is facial recess. What are the boundaries of facial recess? Let me tell you very simply. Please see. This is the facial nerve. This is the first boundary is mastoid segment or vertical segment of facial nerve. My dear friend, from this one nerve come out. Now, this is chorda tympani. The second boundary is chorda tympani. This green star is the facial recess. This is the green star is the facial recess. And my dear friends, this particular, this number 3, the third boundary of facial recess is the short process of incus or fossa incudis. Short process of incus or fossa incudis. My dear friends, let's revise the green star. What is green star? The green star is the facial recess. Why we should learn the facial recess? It's a surgical landmark for posterior tympanotomy. What are 3 boundaries of the facial recess? Look at number 1. Number 1 is mastoid or vertical segment of facial nerve. Number 2, chorda tympani. And number 3 is the short process of incus or fossa incudis. Is everything about cochlear implant is external? No. There is internal component, yes, but there is external component also, my dear friends. External component of cochlear implant. This is the external component of cochlear implant, has 4 parts. Number 1 is microphone. Number 2, this is important. This circular thing is transmitter. This is the T. What is T? Transmitter. Internal part is receiver, electrode receiver. This is transmitter. Number 3 is speech processor. And number 4 is battery. Let's revise once again. Number 1, microphone. Number 2, transmitter. Number 3, speech processor. And number 4, battery. Don't forget circular part, transmitter. So let's go to this choice, beta. Guys, cochlear implant is indicated for, of course, the bilateral profound SNH. So these questions should be very solved nicely. You know them. First is B. And second is C. Okay. Now, Stapes piston process. Now, let this again, very, very, Stapes piston. Now, Stapes piston processes is used for the otosclerosis. What is the name of surgery? The best name of surgery is the stapedotomy. If stapedotomy not in the choice, then stapedectomy. The treatment of choice of otosclerosis is the Stapes surgery called stapedotomy or stapedectomy. Now, otosclerosis means fixation of foot plate of stapes. Okay, stapes is a piston. Okay, you see, this is malleus, this is incus, this stapes. Malleus, incus, stapes. Okay, now stapes head has to be removed, and then you make a hole in the foot plate of stapes, and through that hole you put the stapes piston process over there. So this is the stapes piston process, my dear friend. And let me tell you very, very simple way. Anything like a question mark in the middle ear implants is stapes piston processes. This is mostly made of Teflon or titanium. Teflon or titanium over there. Okay. Now, in, in the otosclerosis, do remember, otosclerosis definitely involves the stapes footplate. But otosclerosis can also involve cochlea, which is called cochlear otosclerosis. Now, cochlear otosclerosis is INICET domain. Stapedial otosclerosis is the common version, but that can also involve cochlea because stape is attached to the old window of cochlea. It can damage the cochlea. If cochlear otosclerosis is seen, then you'll see mixed hearing loss. Mixed. Otherwise, otosclerosis is what conductive hearing loss. And number two, on CT scan, you see double ring sign. Because of the extra white bone formation, double ring sign is symbol. Double ring sign is symbolic. Okay, fine. So the stapes piston processes will be required for otosclerosis. Now, number three is the stapes piston processes, and number three is the aid. Okay, fine. So third is A. Now, torque, total oscillator replacement process. Now, everybody, torque. Now, this is the total ossicular replacement process. Okay. Torp and Cobb. Yeah. Now please see me. Now torp and Cobb. Partial is used when malleus is eroded, incus is eroded, but stapes is still there. In M minus I minus S plus situation, which is Austin type C. Okay. Okay. M minus I minus S plus situation, you go for partial replacement. But in M minus I minus stapes head minus situation, you go for total replacement. Very simple, Vijay. If one ossicle is still left, if stape is still left, then you need the partial replacement. If all ossicle are gone, you need the total replacement. Okay, total replacement. So the total ossicle replacement process is better. That would be required for the ossicle erosion. And finally, the auditory brainstem implant. That would be required for the neurofibroma type 2. So third is actually A, fourth is E, and fifth is D. And I think you can make the answer. I think this one is matching clearly with that. And these questions can really score very nicely, but don't be in a hurry. You just check the first three. You just check the first three, you get the answer better. Because see, in these three, please see, this was same. So one choice is ruled out now. Okay, that's how we do this question. Huh? The moment you go to third one, so either it is this or this, like that. And the fourth one will decide, oh, I know the answer, it is C. Let us revise the auditory brainstem implant also, ABI. The ABI, auditory brainstem implant, that's the ABI. What is the indication of ABI? Neurofibroma type 2. NF2, neurofibroma type 2. What is neurofibroma type 2? I told you in bilateral profound SNHL, we put cochlear implant. But what is the precondition of cochlear implant? Surgery. Normal 8 nerve. Normal 8 nerve. But in neurofibroma type 2, we have got bilateral 8 nerve tumor. Bilateral 8 nerve tumor. Okay. So if 8 nerve is abnormal, cochlear implant is contraindicated. This patient goes for the auditory brainstem implant. So the indication of ABI is one is neurofibroma type 2, of course, yes. And number two is congenital abscess of 8 nerve. Number three, Michel's aplasia of cochlea. Don't forget, better, Michel's aplasia. Michel's aplasia of cochlea. Aplasia of cochlea. And number three is congenital abscess of the 8 nerve. So the way we put the ABI electrode. ABI electrode is placed in lateral recess of fourth ventricle. Lateral recess of fourth ventricle. Okay. How to remember an easy way, beta? How always study like this, beta? How would you recall the data on the exam day? Please see. ABI, what is the indication, beta? NF2. Neurofibroma type 2. Please see 2 into 2. 2 into 2, fourth ventricle of brain. So ABI electrode is placed in fourth ventricle of brain. Are you getting how to study? The study should be useful on the exam day. So please study, keeping in mind how to recall the data on the exam day. Now, can we go further now? Everybody, are you aligned with me? Everybody, are you able to really correlate? Fine. Yes. Fine. Okay. Now, 17-year-old male present with the history of right-sided reddish firm nasal mass with history of recurrent nasal bleed. So please see, there's a young chap who is a male, adolescent guy. There is a nasal mass and recurrent nasal bleed. I think we make up your mind like that. It's an angiofibroma question. Conductive hearing loss, yes. Why? Angiofibroma is a nasopharyngeal tumor, and nasopharyngeal opening of eustachian tube is blocked. That can lead to glue ear in this case. Hyponasality of voice. What is the other name of that? Everybody, don't forget. It's called rhinolalia clausa. Whenever nose is closed, that dull, typical dull voice is called rhinolalia clausa. Rhinolalia clausa. Rhinolalia clausa. Okay, don't forget this word. This can be asked in the exam. Rhinolalia clausa means nose is rhino means nose, clausa means closed, nose is closed. Simple word is dull voice or hyponasality of the voice. The CCT shows enhancing mass in the right nasal cavity, filling the nasopharyngeal area. Don't forget, angiofibroma is not a nasal tumor, it's a nasopharyngeal tumor. Angiofibroma is the most common benign tumor of nasopharynx. It's a benign but locally invasive tumor. So it can go to nose and other areas. And unfortunately, the tumor has gone to the right side pterygopalatine fossa. That's the biggest clue over here. What is the Redkowski staging of this tumor? Okay, Redkowski staging is very favorite of INCT. Let us see over here with the Redkowski staging. Now, the stage 1, stage 2, stage 3, stage 4. Very easy, but very easy. Let's not complicate this one. Now, my dear friend, this is the nasopharyngeal tumor. First of all, it goes to nose and sinus and patient had nasal mass and epistaxis. I hope you remember there is a bone here with sinus, maxillary sinus, and this bone is, of course, again the maxilla. Now, the space behind the maxilla is called pterygopalatine fossa. This is pterygopalatine fossa right now, and the cheek area is infratemporal fossa area. Infratemporal fossa. My dear friends, this is the pterygopalatine fossa, and this is the infratemporal fossa. Infratemporal fossa. And this is, of course, the nose and sinuses. Nose and sinuses. Okay? Plus, first orient now. I'm going to remove all this marking for you guys, and I'm going to draw it again. I'll tell you why. Because I want you to remember the stage in an easy way. Okay, fine. And this is the infratemporal fossa. My dear friends, please see. Stage 1, from nasopharynx to nose and sinuses is stage 1. If the tumor comes from nasopharynx, and this tumor starts from nasopharynx, and tumor goes from the nasopharynx to nose or sinuses, it's called Redkowski stage 1. So 1A is nose involvement, 1B is sinus involvement also. So if the tumor goes from nasopharynx to nose, it is stage 1A. From nose to sinus is also with a stage 1B. Now, if tumor just minimally enter pterygopalatine fossa, this is stage 2A. If tumor frankly involved pterygopalatine fossa, this is called stage 2B. Right now, stage 2. My dear friend, this is stage 2A. This is stage 2B. 2A, 2B. And if it goes to infratemporal fossa, it is stage 2C. Stage 2C, beta. Stage 2C. Okay, fine. Everybody, please see. Let us do, beta. Very easy. Everybody, please see. Yes, please see. Tumor start from nose, nasopharynx. If it comes to nose, 1A. Nose to sinus, 1B. If it is minimally entering pterygopalatine fossa, right now, 2A. And if it is frankly involving terminal fossa, 2B. And if it actually involves the infratemporal fossa also, then it's stage 2C. And if it goes to brain, then answer is stage 3. You tell me, beta. You tell me, beta. You tell me, could you relate it? Because everything has not to be made difficult, beta. It's a 19 subject game. You cannot complicate things too much and really not recall. You have to be sure. I know this is 2C. Yes, 2C. Fine. This is 2B. This is 2A. And this is, of course, 1. That is, wow. Now, everybody please see. The answer to this question is right-sided pterygopalatine fossa involvement. You know now, no doubt, better. Stage 2B. Do I need to tell you now? Whenever they say it's involved, it's considered frankly involved. Don't worry, you will be never asked limited involvement and all that. Don't worry. Tell me, everyone, please comment in the chat box. Do you agree that this kind of learning is better? High concepts, scientific concepts, but in a high yielding manner. In a way, we can recall it also. Okay? Now, everyone, chalo. Next one, beta. Next one, beta. Now, this when the tumor is growing in the pterygopalatine fossa, my dear friend. Beautiful question, beta. The tumor is growing in the pterygopalatine fossa. Everybody, please see. Then it, and then inflatable. Please see, beta. When it's growing over here, what does it do? It pushes the posterior wall of maxilla forward. Can you see, beta? The tumor is pushing the posterior wall of maxilla forward. This radiological sign on CCT is called Hallman-Miller sign. This is called Hallman-Miller sign, beta. Now, very likely question. CCT shows Hallman-Miller sign on the radiology, beta. Please see. First of all, this is contrast on CT, and this is the normal side, and this is the tumor site. This is the tumor, the red arrow. M is maxilla, and this is the posterior wall of maxilla, and this is the posterior wall of maxilla. So tumor is pushing the posterior wall of maxilla forward. This red arrow is the tumor over there. This red arrow is the tumor over there. Tumor is pushing the posterior wall of maxilla forward. That's a Hallman-Miller sign. What extra we do? We do angiography also. What is the role of angiography? To find out the source of main blood supply of the tumor. The most common source of blood supply of angiofibroma is maxillary artery. Maxillary artery. And the maxillary artery, what you should do with that, beta? Pre-operative embolization. Pre-operative embolization of this artery will reduce the blood loss during surgery. Pre-operative embolization of this artery will reduce the blood loss during this surgery also. Why angiofibroma bleeds more? Because it is made of blood vessel. Very famous question. Why angiofibroma bleeds more? It is made of blood vessel, and the tumors of this blood vessel do not have muscular layer. So once cut, they cannot contract. That's why they keep profuse recurrent epistaxis. Why it is seen in adolescent male of 12 to 18 years? It's a testosterone dependent tumor. So pre-operative flutamide will shrink the tumor. Dr. Dhawan, apart from Redkowski staging, is there any other staging we need to remember? Yes, fish staging, brother. Just casually. Fish staging is to be remembered. Why angiofibroma is the core favorite topic for INCET particularly. So you have to remember Redkowski and fish also. Now, please see, brother. It's like fish type 1, type 2, fish type 3, and fish 4. 4 is always brain, brother. No problem. Brain. Now, please see. Tumor can go to nose, to sinus, to cheek, to orbit, to brain. Very simple. Please see, brother. Please see. So long as only nose and nasopharynx is mentioned, it is type 1. Moment it says pterygopalatine fossa is involved. Pterygopalatine fossa, remember behind maxilla, or sinus involved. Any sinus involvement is stage 2. And if they say infratemporal fossa or orbit is involved, stage 3. And brain, stage 4. Okay. Now, please see, let's fish staging of angiofibroma. Type 1 is nasopharynx and nose. Type 2 is either sinus involved or the pterygopalatine fossa involved. Stage 3 is infratemporal fossa involved or orbit is involved. And stage 4 is brain involved. Once again, the fish staging is if nasopharynx and nose involved, 1. If pterygopalatine fossa or sinus involvement is there, then stage 2. Infratemporal fossa or orbit involvement is there, stage 3. And brain involvement is stage 4. Stage 4. Okay. Now, glomus jugular. Dr. Dhawan, for INCET, do you remember? We have to remember any other staging? Yes. Yes. Ugo fish. Fish staging is for angiofibroma also, and fish staging for glomus jugular also. You know, glomus jugular is highly vascular tumor again. Okay. And this is more common in female. G for glomus, G for girls. Girls get glomus. Males get angiofibroma. Adams get angiofibroma. Girls get glomus. A young boy, nasal mass, epistaxis is definitely angiofibroma question. A lady with something pulsating or bleeding in the ear is glomus question. Now, it has got again type A, B, C, D. A, B, C, D. C will be asked. I'm telling you already. C will be asked. This tumor belongs to the, ear. So it's below the floor of the middle ear. If it goes to middle ear, okay, A. If mastoid is involved, please, main word, middle ear involved is, of course, the stage 1. Mastoid involved is stage 2. But if they mention carotid canal involvement, that it is skull-based tumor and carotid canal is involved by the tumor, it is type C. My dear friend, C for carotid. C for carotid also, na? C for carotid also. Okay? You can remember C1, C2, C3 also, but at least remember this one. Type C is carotid involvement and type D is brain involvement. Once again, if tumor goes into middle ear, globus tumor, middle ear. Rising sun sign. Everybody tell me, do you remember rising sun sign? And can you correlate? Rising sun sign is stage type A. Can you correlate this one, brother? Tell me. I want everyone to answer in the chat box. Be active, brother. Right? Tumor is below the floor of middle ear. It grows into middle ear from below upward into hypotympanum. There's a rising sun sign. That is fish stage A. Fish stage A, brother. Are you able to correlate, brother? Okay. Number two is if middle ear to mastoid. B. C for carotid, canal movement. C. And brain involvement is D. Very good. Fine. Fish is for glomus jugular. Fish is for glomus jugular, my dear friend. Very good. Now, allow me to go next question. This is a very, very debatable question, and people say that it's tough. It's not tough. It's eye-opening question for me. 40-year-old patient is giving history of foul-smelling ear discharge. My dear friend, foul-smelling ear discharge. Everybody, moment you see foul-smelling ear discharge, there is only one answer. Chronic foul-smelling ear discharge is unsafe CSM or aticoenteral CSM. Let me tell you 4 MCQs of your exam. Chronic foul-smelling ear discharge, it is unsafe CSM or aticoenteral CSM, means cholestoma is there. Now complications are there. If chronic foul-smelling ear discharge with vertigo happen, like this patient, vertigo, the answer is unsafe CSM with labyrinthine fistula of lateral semicircular canal. Number 2, chronic foul-smelling ear discharge with headache, vomiting, convulsions. Convulsions, it is otogenic brain abscess of temporal lobe. Headache, vomiting, convulsion. It is brain abscess due to ear infection. Most common site is temporal lobe. And treatment is neurosurgery. Treatment is neurosurgery. Okay? Neurosurgery. Okay? Fine. Now, the third one is chronic foul-smelling ear discharge with headache, spiky fever, and edema on the mastoid. Headache, spiky fever, edema on the mastoid. Answer is sigmoid sinus thrombosis, also called lateral sinus thrombosis. Thrombosis always lead edema. Edema, DVT, deep vein thrombosis lead to edema of the limbs. Similarly, sigmoid sinus thrombosis, some edema will be there. Mastoid edema with headache in a backdrop of, fever, and the past history of chronic foul-smelling ear discharge, you know the answer. Chronic suppurative otitis media, unsafe or aticoenteral CSM. You can say, Dr. Dhawan, mastoid edema, we can write mastoiditis also. No. In mastoiditis, there is no headache, no spiky fever. In mastoiditis, there is no headache, no spiky fever. So let me tell you one secret. If ear discharge patient has headache, answer will come out of brain only. If ear discharge patient got headache, answer will come from brain only. Now look at this patient. It's a complication of unsafe CSM because patient developed vertigo. Vertigo. Why vertigo? It's a labyrinthine fistula of lateral semicircular canal. Cholestoma is the hallmark of disease. Of cholestoma eats the bone. Cholestoma eats the bone. So cholestoma has actually eroded this much bone. Due to that, what happened? The real canal got exposed. This is a labyrinthine fistula of lateral semicircular canal. It is due to bone eroding properties of cholestoma. That's why vertigo is happening. How we check that, beta? How we check that? Fistula sign is positive. How we check fistula sign, beta? We use a Seagull speculum. We put air in the ear, beta. The moment you put air in the ear, you will get nystagmus over there. The moment you get air in the ear, you will get nystagmus. What is nystagmus? Rhythmic oscillatory movement of eyeball, beta. Moment you put air in the ear, the eyes start dancing, beta. Eyes start dancing. Okay, oh, fine. Okay, fine. Now, everyone, the treatment. The treatment of, like choice will be, of course, the surgery, and you cover the fistula with the, now, next one, beta. Next one, sorry. This is the sequence. Now, let's please see what happened in this patient. 1 week back, he developed vertigo. Fistula sign is positive on clinical examination. Fistula sign is positive on clinical examination. Okay. So there was diagnosis till now was labyrinthine fistula of lateral canal. He was offered surgical treatment, which he denied. People will go back home. This morning, he presented with history. After a few days, he presented the history of total loss of hearing on the right side because he spent few days. What happened, beta? What happened? If you don't get the labyrinthine fistula treated, then what will happen, beta? What will happen? There will be the dead inner ear. So, labyrinth fistula, if not treated, it became dead inner ear. That is why now this patient has got dead inner ear. Fistula in dead inner ear will lead to false negative fistula sign. There is fistula. Look at me. There is fistula. But if inner ear has become dead by now, even if you put air into this inner ear, which is dead, there is fistula, but test will come negative. So this will be false negative fistula sign. Okay. Now look at this patient. The fistula sign has turned negative. But this is not actually negative. It's a false negative. Why? Because patient denied treatment and the inner ear became dead due to problem of the inner ear infection. And now it is a case of dead inner ear. Fistula in dead inner ear lead to false negative fistula sign. So this is false negative. This dead inner ear will lead to unilateral severe SNHL. Dead inner ear will lead to unilateral severe SNHL. Anybody, what type of Rene test is seen in unilateral severe SNHL? Can you tell me? What type of Rene test will be there, beta? The answer is false negative. Because in SNHL, Rene is positive, beta. In SNHL, Rene is positive. The answer to this question is C. Let me summarize, beta. The primary diagnosis was unsafe CSOM with labyrinthine fistula of lateral canal. But patient did not take treatment. The inner ear became dead due to infection. Now there is fistula in dead inner ear. That is why we get false negative fistula sign. Dead inner ear will lead to unilateral severe SNHL, and that is why we are getting the false negative fistula sign. How many of you could relate to and understand this concept? I want to hear from everyone. Could you get clarity? People say it's a difficult question. Now, this is the beauty of the question, beta. Because the dead inner ear will lead to unilateral severe SNHL and you will get a false negative Rene in this case. Please comment. Please comment, everybody. Okay. So Rene will be false negative in this case. Okay, fine. Great. Great. Just guys, let's quickly remind ourselves. Rene negative means conductive hearing loss. BC. Rene negative is conductive hearing loss. And Weber heard in the poor ear means conductive hearing loss. All of you, how do we do Weber? Please see. We keep the tuning fork in the center of the head. We ask the patient which side you are hearing it. Okay, fine. Everybody, please see it like that. So all of you do one thing with me. Let us produce conductive loss in our body to remember Weber test. All of you press the tragus of this side. Press the tragus. Press the tragus. This is poor ear. It's conductive hearing loss. Say 1, 2, 3. After pressing your tragus, say 1, 2, 3. After pressing your tragus, say 1, 2, 3, beta. It's a poor ear suffering from conductive hearing loss, and you know you're hearing your own sound on this side. You're hearing your own sound on this side, beta. It will help you remember in the exam. Weber is heard in the poor ear in conductive hearing loss. Okay? And ABC poor means SNHL. That's very simple. If Rene is given negative and Weber in the poor ear, the answer is conductive hearing loss. Okay? Answer is conductive hearing loss. And if Rene is given positive, and Weber in the better ear, the answer is SNHL. Answer is SNHL. Okay, to find. And by chance, please see, if Rene is given negative and Weber is heard in the better ear, please understand, brother. Please understand. It's a very incoherent thing. Rene negative means conductive hearing loss. Weber better ear means SNHL. Can you make any sense out of this, brother? Rene negative will say conductive hearing loss. Weber better will say SNHL. Can you make any sense out of this? No, no. Write down nonsense. When it sounds nonsense to you, the answer is the false negative Rene situation. The answer is unilateral severe SNHL. So let me summarize with everybody. If Rene is negative and Weber is heard in the poor ear, conductive, Rene positive, Weber in the better ear, it's SNHL. But if Rene is given negative and Weber in the better ear, it's a nonsensical situation. Please mark unilateral severe SNHL. You're diagnosed a very good case of false negative Rene. Now, just we can grade the conductive hearing loss on the basis of tuning fork findings. The three tuning fork we use: 256, 512, 1024. My dear friend, it's again a question, PYQ, all of you. If Rene is negative for 256, but positive for these two, 512 and 1024, not too much conductive hearing loss. 50 to 30. This is conductive hearing loss element. Okay, fine. Now, but if Rinne is negative for 256 and 512 and positive for 1024, then 30 to 45 decibel, moderate conductive hearing loss. And lastly, if Rinne is negative in all three, then 45 to 60 decibel conductive hearing loss. 45 to 60 decibel conductive hearing loss. This is an important question, but once again, let's revise. If Rene is negative in 256, but positive in remaining two, not too much loss, but 15 to 30 decibel. If Rene negative for 256 and 512 and positive for the 1024, it is going to be 30 to 45 decibel conductive hearing loss. But if Rene is negative for all three, then it will be 45 to 60 decibel conductive hearing loss. Now, again, audiology is asked very commonly in the INCET, of course, NEET PG also. Which of the following is not an objective audiological investigation? Not an objective. So there's OE, impedance audiometry, also called tympanometry, plus stapedial reflex is there along with that, and BERA or auditory brainstem audiometry, and visual reinforcement audiometry. Let's revise quickly. There are two types of audiological investigations. One are subjective, other are objective. Let's do the first one. This is of number one, BOA. Subjective number one, BOA. Behavioral observation audiometry. This is used for 0 to 6 months of baby. It's very, very important slide, but very important slide. This is very important slide. Behavioral observation audiometry. Please see, do you do this? And patient startle like that. Behavioral, you observe the behavior, but it is subject dependent. Subject has to respond. Okay, fine. Number two, visual reinforcement audiometry is for 6 months to 2-year baby. What do? You give some sound, and when the baby looks at a speaker, you blow a toy over there. Visual reinforcement. Again, subject has to look at the toy. Okay. Number three, play audiometry. You have to play with the child. Give me a yellow colored card, like that. He can understand some words now. 2 to 5 years. And lastly, which we do normally, pure tone audiometry is for above 5 years. Once again, this is a very, very important slide. Behavioral observation audiometry is for 0 to 6 months. 6 to 24 months is the visual reinforcement audiometry. 2 to 5 years is play audiometry. And more than 5 years, we go for pure tone audiometry. These are subjective tests. But what are the objective tests? Objective means when the subject is not involved. When the subject is not involved, BERA, brainstem evoked response audiometry, then otoacoustic emission. They are the echoes produced by outer hair cells of cochlea. Acoustic reflex is stapedial reflex. Stapedial reflex. Okay, stapedius contract on the loud sound. And tympanometry. These two are together called as impedance audiometry. All these four are objective. In all these four, subject has not to participate in your test. You put a machine and you take the answer from the machine only. That is what the thing will be. Everyone, let's revise one more time. The objective tests are the one BERA, OE, impedance audiometry means, tympanometry or acoustic reflex. But the play audiometry, the visual reinforcement audiometry, the behavioral audiometry, or the real pure tone audiometry are subjective tests. So let us go to this question. The answer to this question will be, of course, visual reinforcement audiometry. Remaining three are objective tests. This one is subjective test. Now, BERA is objective test. BERA is the gold standard test for hearing loss. BERA has 7 waves. You give sound and you record the current from the auditory pathway, which is E. coli Ma, and the most important wave is wave 5. Wave 5. Now, question is waves. The source of wave, that's MCQ. First and second wave come from 8 now. E. coli Ma, 8 now. Okay. Then third wave come from the cochlear nucleus. And this is very, very important. I'm telling you, if you are following the paper, you know it's asked. And O comes from the fourth wave comes from the olivary complex superior. And most importantly, the wave 5 is from lateral lemniscus. Please at least remember these. Okay, right. Once again, first and second wave come from 8 now. Okay, third wave, cochlear nucleus. Fourth wave, olivary complex superior. And fifth wave come from lateral lemniscus. Okay. Most one thing is, Bara is gold standard, yes. But Bara does not check which level, beta, auditory pathway. Bara miss cortical deafness, beta. Cortical deafness. So for this, we have another test called SERA. Okay, SERA. What is SERA? Cortical evoked response audiometry. What is SERA? Cortical evoked response audiometry. What is ASSR? It's also objective test. It's just like BERA. BERA is also objective. The other type of BERA is ASSR. Other name of BERA is auditory brainstem response. But ASSR is different from BERA. This BERA is not frequency specific. When you do frequency specific BERA, it is called ASSR. What is ASSR full form? Auditory steady state response. Auditory steady state response. It's also similar to BERA objective test, but it is frequency specific BERA. Now, OAE, beta, auto acoustic emission, very important topic. When you give sound to the baby, and if the cochlea is processing the sound, some echo come back from cochlea. Those echo are called auto acoustic emission, and they are produced by outer hair cells. O for O. Outer hair cell produce auto acoustic emission. Okay, fine. So if echo are coming, then it means the cochlea is working normally. Okay. Now, the three type of OAE, beta. If you don't give any stimulus, still the echo come. It is spontaneous. If you give one stimulus and one echo, transient evoked. If you give two stimuli and you record two echoes, distortion product. Most commonly used OER, of course, most commonly used OER, TOE. Transient evoked, one stimulus, one response is the best type of autoacoustic emission, is the PYQ again. Transient evoked are used more commonly. Fine. Now, this is expected question again. Ideal hearing screening investigation in neonates. Neonate is OE. OE. But meningitis baby, NICU baby, low birth weight baby, congenital hyperbilirubinemia baby, syndromic babies, you go for BERA. BERA is also called ABR. Okay, if you there's a meningitis baby, you want to do hearing loss, rule out hearing loss, go for BERA. Go for BERA. Now, next question. Which of the following is the right grading of retraction of tympanic membrane shown in the given otoendoscopic image? I know it's a very troubling thing for the undergrads actually, which is what actually. First of all, there are two parts of the tympanic membrane. The lower part is called pars tensa. Pars tensa, and this part is called pars flaccida. Actually, Sade classified the grading of pars tensa and TOS classified the grading of pars flaccida. Now, first of all, Sade's classification. This question is Sade. Sade is for the grading of the pars tensa retraction. When you stick into this block, negative pressure in the middle ear, it will suck the tympanic membrane. Grade 1 is just mild retraction. This is grade 1. Nothing big deal. But the moment you start seeing the tympanic membrane is so much sucked inside, it start touching the incus. You can see the incus through the retracted tympanic membrane. It's grade 2. Grade 2. Okay. And if it start touching the promontory on the medial wall of middle ear, but still there is some air left between the two. When you do the seagulization, still show some movement. It is grade 3. That is called atelectatic. This is the atelectatic. And grade 4 is totally adherent to the promontory of the middle ear, and there's no movement of tympanic membrane on seagulization also. Then it's grade 4. Grade 4. Once again, grade 1 is slight retraction. Slight. The main word grade 2, incus. If incus is visible through a retracted TM, it's grade 3. Sorry, grade 2. Grade 3 is it is going and attaching to promontory, but still not attached to promontory. Still, it can move with seagulization. And grade 4 is adhesive. It is adherent to the promontory. Okay. Grade 3 and grade 4 differences. Grade 3 is called atelectatic. Still some air is there. And grade 4 is adhesive. Adhesive. Okay, fine. Now look at the question below. I think now you know. Everybody, can you comment? Incus is draped by the retracted TM. So this is grade 2. Grade 2. Grade 2. Most of the time they'll ask you grade 2 only. Because grade 2 is very easy to, like ask because there is a very typical finding incus visible. But if it is showing totally draped to the middle ear medial wall, it can be grade 3, grade 4, but they'll have to write over there whether there's a movement on the cingulation or not. Okay. Let us do the TOS grading. TOS actually has graded the retraction of the pars flaccida. Pars flaccida. This one. Okay. Now, if it is just a small attic dimple, only a little bit of slight retraction. Slight retraction will never come. Don't worry about it. Actually, they will show you a little bit more than that. But if pars flaccida is so much retracted that it is adherent to the neck of the malleus, right behind the, look at me, beta. Right behind the membrane is this is malleus, beta. This is grade 1. But if it start getting adherent to the neck of the malleus, which is the first ossicle behind the membrane, it's grade 2. Grade 2. Now, but grade 3 and grade 4 are very, very important to be asked. Now, grade 3 is there is erosion of sputum also. Means it has gone beyond the malleus. It has extended beyond the malleus, but still you are able to see the full extent of retraction. Look at me. Let me show you grade 3 below. This is the gadda. This gadda is called grade 3. Can you see there is some bone was there, but that bone has been eroded. Otherwise, you never see this gadda. Okay. Okay, fine. So this is grade 3. Why? You are able to see the end of the retraction pocket over there. Grade 3. Grade 4 is similar, but it is so big. Scutum is eroded, this bone is eroded, yes, but you're not able to see the end of it's going further deeper inside. Further deeper inside. Once again, the first picture is a TOS grade 3 and TOS grade 4. Mostly TOS 3 or TOS 4, grade 4 will come better. So TOS grade 1 is slight retraction. TOS grade 2 is it is approaching, attaching neck of malleus. Grade 3 goes beyond malleus, but still the full extent of the retraction is visible, but there will be definitely erosion of scutum. Okay, 4. Scutum is the outer bony wall of attic. And the grade 4 is similar as grade 3, but you cannot see the end of the retraction over there. End of the retraction over there. Could you relate to a grade SADE and TOS classification? SADE is let's once grade 1 slight, grade 2 incus visible, grade 3 atelectatic, grade 4 adhesive. Then TOS grade 1 slight dimple, grade 2 attaching to malleus is visible now. This one. Please see SADE grade 2 incus is visible. Here incus, here grade 2 TOS neck of malleus is visible. Grade 3 sputum eroded, but full retraction is visible. Grade 4 sputum eroded, but full retraction is not visible. It's bigger retraction over there. Are you able to relate to it better? Tell me in the chat box, could you? Okay, fine. Now everyone, one more grading is very, very asked. Cotton-Maya grading of congenital subglottic stenosis. You must remember this one. Please see, what is subglottis? It's a space in the cricoid ring. It can be narrow. How we see it on CT scan? CT scan, please see, this is the normal size of the subglottic area. Fine. Now imagine it is 0 to 50% block. 0 to 50% block. 0 to 50% block like that. That's the grade 1. That's the grade 1. Grade 2 will be, 51 to 70%. Grade 3 will be 71 to 99%. And grade 4 is no lumen detectable. This is grade 4, no lumen. This is grade 3, grade 2, grade 1, and this one is normal. Once we've done, please correlate now. Grade 1 is 0 to 50% blockage. Okay. Grade 2 is 51 to 70%. Grade 3 is 71 to 99%. And grade 4 is no lumen detectable. In grade 3, grade 4, you need to do a bigger surgery. But for grade 2, grade 1 does not need any treatment. Grade 2, you have to do the dilatation with the laser or bougies with them. And after that, you apply mitomycin C. This drug is useful for laryngotracheal stenosis. Okay, fine. Now, the grade 3 and grade 4 would need proper surgery, laryngotracheal reconstruction. After that, you put which tube? Montgomery silicon tracheal T-tube. Montgomery silicon tracheal T-tube. So grade 1 does not need any treatment. Grade 2, you need laser dilatation, but followed by mitomycin C. Mitomycin C is anti-fibroblastic drug. There are 3 MCQs of this drug in ENT. Number 1, for the choanal atresia surgery. Number two, to prevent the adhesion formation or synecdoche formation in nose after any nasal surgery. And number three, this one for laryngotracheal reconstruction surgery. Now, 14-year-old patient is brought to ENT OPD with the chief complaint that she's able to hear the sound. Very interesting case, beta. She is able to hear the sound, but has difficulty in understanding. Understanding is a brain function. Okay, fine. Hearing is a peripheral thing. Her pure tone audiometry and BARA responses are inconsistent, but PTA being more or less normal. The peripheral cochlear function is absolutely normal. What is the likely diagnosis? It's a very, very important domain again. The answer is this: auditory neuropathy. Now, what is auditory neuropathy? Please let's revise. Cochlea is normal. Eighth nerve is not normal. Eighth nerve, what is the problem in eighth nerve? Eighth nerve problem is there is desynchronization of action potential in the eighth nerve fiber. The cochlea is normal. Cochlea is normal, but eighth nerve is not normal. So there is desynchronization of action potential in eighth nerve fiber. Guys, please look at me. See, if cochlea is normal, in OAE, you check cochlea. In pure tone audiometry, you check cochlea only. They will be normal. They will be normal. But BARA is produced by E. coli ma. E. coli ma, na? E. coli ma. E for 8 now. So BARA will be abnormal. So whenever you get a situation that hearing is okay, but understanding is not okay, then think about this possibility. In this patient, cochlea is normal. So otoacoustic emission, pure tone audiometry will be normal. But eighth nerve is abnormal. What is the problem in eighth nerve? Desynchronization of action potential of the eighth nerve fibers. So BARA will be abnormal in this case. So the answer to the question is auditory neuropathy. Auditory neuropathy. Now, the nerve blocks have been asked many times. The nerve blocks very important. Okay, let us see where to answer what. Actually, they're coming from the nasociliary nerve is the branch of the ophthalmic division of the trigeminal nerve. So nasociliary gives one more branch outside, and that is the anterior ethmoidal nerve. You fine? Please see. Now, if they ever show you the needle going deep into orbit, then you are actually anesthetizing the main nasociliary trunk. If you put xylocaine, lignocaine, deep towards the medial wall of the orbit, deep towards the medial wall of the orbit, it's a nasociliary block, and you're actually anesthetizing the main trunk of the nasociliary nerve. Okay? The branch of this is anterior ethmoidal nerve, which comes out. So if the picture shows that the injection is being given over the right side of the nose, actually, it's anterior ethmoidal block. Once again, please compare. If the syringe needle is going deep towards the middle, along the middle of orbit, deep into the orbit, you are anesthetizing the main nasociliary trunk. So it's a nasociliary block. But if you are giving the injection on the side of the nose, over here, it's the anterior ethmoidal block. Anterior ethmoidal block. And my dear friend, this picture is going deep into the orbit. So answer this question will be, of course, the nasociliary block. Everybody, could you understand this one better? Okay. Everybody, are you able to understand now? So if it go deep in the orbit, medial wall, nasociliary. The outside on the side of nose, anterior ethmoidal block. Okay. Now, say yes or no. Everybody, no. Next one. 45-year-old lady presented the ENT OPD with the complaint of long-standing right-sided nasal congestion. Often on discharge, there is decreased sense of smell and dull voice is there. Rhinolalia clausa. CT scan is shown over there. Now, very favorite topic. You know it every time they ask one or other thing like that. Is it Ringer's tumor? It's AC polyp, fungus sinusitis, or maxillary cancer. Now, how to rule out the choices? First of all, A and D are not possible because there is no epistaxis. Ringer's tumor and maxillary cancer will have definitely epistaxis. It's either enteroconal polyp or allergic fungal rhinosinusitis. Now, my dear friend, enteroconal polyp is a homogeneous edema. Homogeneous edema. So, in that case, in the enteroconal polyp, because and this is a beautiful, enteroconal polyp. So, okay, it's just nothing but edema only. So, this is a homogeneous opacity in the maxillary sinus. So CT scan in enteral polyp will show you homogeneous opacity. But fungal sinusitis, look at me. This is a fungal polyp. This is the enteroconal polyp, neat and clean polyp only, beta, homogeneous. But look at the AFRS, beta, fungal rhinosinusitis. Can you see this whitish fungal debris also? Okay. And this is the polyp. So you will have heterogeneous opacity or double density shadows on CT scan. So whenever you see the double density shadows in the backdrop of polyp or discharge or something like that, it's the AFRS patient, allergic fungal rhinosinusitis. And if it's a homogeneous polyp, of course, enteroconal polyp. Now, the typical the typical situation in the fungal sinusitis is this one. Please see this one is the allergic nasal mucin. Allergic nasal mucin. Allergic nasal mucin. Now, this mucin has got very thick resinous tendency, the consistency. And if you say, the books say that it has peanut butter appearance. And if you just take a small drop and see it under microscope, you will see eosinophils, Charcot-Leyden crystals, and of course the fungal hyphae. Fungal hyphae. So this is allergic element. This is the fungal element. This is the allergic element. This is the fungal element. Allergic element, fungal element. Okay, fine. Okay, fine. Guys, are you able to understand allergic and fungal element? Now this is majorly type 1 hypercell reaction, and this particular disease is seen. This particular disease is seen in the immunocompetent patient, and it's called by Aspergillus fumigatus. Fumigatus. Okay. And there's a very famous criteria, which is MCQ also, Bent and Kuhn criteria. There are major and minor criteria. This is a question P by Q. What are major criteria? All are major criteria except type 1 hypersensitivity. Yes. Nasal polyp, yes, which are mixed with the fungal debris. Typical CT finding, yes. Eosinophil in the mucus, I told you, yes. And fungus on the nasal smear, yes. But fungal culture is a minor criteria. Minor criteria. Are you getting my point, beta? All are major criteria except. All are major criteria except, beta. So type 1 hypersensitivity, yes. Nasal polyp are there, yes. Typical heterogeneous opacity on CT scan, yes. Eosinophil and fungal hyphae on the nasal mucus, yes. But fungal culture proving is not required. Okay, fine. Now, everybody, next one. So, there are three nasal masks, everyone. Now, let's revise the three nasal masks. Three MCQ of exam. Three nasal masks and three MCQ exam. Everyone, look at me. Now, first of all, enteroconal polyp. Unilateral nasal mass growing backward without epistaxis is enteroconal polyp. Unilateral nasal mass growing backward without epistaxis is enteroconal polyp. My dear friend, polyps never bleed. Number two, Ringet's tumor or inverted papilloma. Inverted papilloma, you see, there's reddish firm nasal mass with epistaxis, mostly a male in 40 to 60 years. Mostly a male. A reddish nasal mass, okay, 40 to 60 years, and with epistaxis is inverted papilloma. The third one, you all know, rhinosporidiosis. There is a lot of clarity on this topic. Patient will be coming from South India, coastal areas, Tamil Nadu. Number two, the history of contact with the pond water or some water. Generally, a villager, cattle breeder, something with the water contact because Rhinosporidium zebra is in the water. And this mass is a reddish, firm nasal mass with irregular studded surface. Irregular studded surface. Guys, this cannot be confused, better. First of all, look at the mass, better. If it is not bleeding, it's most likely polyp. If it is not bleeding, it cannot be tumor or rhinosporidiosis. These two have got epistaxis for sure. Are you getting my point, better? Fine. So, If it is a background, now look at these two marks with two episodes. Background South India, farmer story, pond contact, irregular mass, rhinosporosis. Just like a nasal mass, which is bleeding also, CT scan finding is given. Please mark Ringet's tumor or inverted papilloma nose. Now read your INICT question, everybody. Everybody read the INICT question. 50-year-old male present with right side pinkish red nasal mass with epistaxis. With epistaxis. Okay. Some scan image is given. Now please see. It has to be something like a tumorous thing. How? Why it cannot be JN? It's 50-year-old male. JN angiofibroma is 12 to 18-year male. Okay, number one. Number two is the inverted papilloma, maxillary sinus carcinoma, or ethmoidal carcinoma. Now, please see a tumor which is arising from lateral wall of nose over here, and it's locally invasive tumor going this way, that way. It has to be inverted papilloma or Ringet's tumor. Ethmoid is here, but this is ethmoid, my dear friend. Ethmoid will be expanding this area, but this is ethmoid. It's not. Okay, fine. Okay. So, in this case, why we should not mark the maxillary carcinoma? Because the contours of the maxilla, the walls of maxilla are still preserved. The mass is coming from the nasal side to the maxillary side. Okay. Anyway, more common tumor is inverted papilloma. Inverted papilloma. And maxillary carcinoma will certainly have what, beta? Cheek swelling, cheek anesthesia, or orbit involvement mentioned, something like that. Cheek swelling, cheek anesthesia, orbit involvement, or loss of upper teeth will mention over there. Okay, that's a different domain altogether. It's a typical scenario of inverted papilloma. Now, tell me this question, would you be able to handle these kind of question or not? The best treatment for Ringet's tumor is the medial maxillectomy by Moore's lateral approach or Moore's lateral incision. The best surgical management for Ringet's tumor, inverted papilloma, is medial maxillectomy. Why medial maxillectomy? Because inverted papilloma arises from lateral wall of nose. Lateral wall of nose is nothing but medial wall of maxilla. Medial wall of maxilla. Okay, fine. Now, X-rays, beta. X-rays are asked very, very commonly. Okay. Now, which one, beta? First of all, it's a sinus X-ray. Okay. Either it is water view or cardival view. The two view. Beta. Two view. Schuller's and Townie's are for ear, mastered view. They are for the ear. Let me tell you one very simple, straightforward thing. If maxillary is clearly visible, it is water view. If maxillary is not clearly visible, it's cardival view. If maxillary is not clearly visible, it's cardival view. Beta. You can ask me, Dr. Dhawan, what is P-Ray's view then? P-Ray view is nothing but water view plus open mouth is P-Ray view. Like for this, mouth is open. Now this is sphenoid sinus. Why mouth is open? Beta? To include the sphenoid sinus, the best name of this X-ray would have been P-Ray view. Beta. But what is P-Ray view? Water view plus open mouth is equal to P-Ray view. But if P-Ray view not the choice, then it's water view only. Don't worry about it. So scan the choices first of all. If P-Ray is not there, it's either water view or cardival view. If maxillary clearly visible, water view. If maxillary not clearly visible, it's cardival view. If by chance maxillary is clearly visible and open mouth is also there and choice has got P-Ray view, then of course P-Ray view is the better answer over there. Beta. Okay, but fine. And let's see, beta. This is occipitomental view. Occipitomental view. This is occipitofrontal view. This shows maxillary most clearly. This shows frontal and ethmoid more clearly. This is INICT question, beta. If any time you don't see the maxillary not clearly visible, please mark cardival view beta over there. Okay, fine. So, P-Ray view is nothing but water view plus open mouth. Beta. Now, lately they've been trying to give the how we're doing X-ray beta like that. Please see bache over there. If chin is touching the X-ray plate, it is water view. If chin is touching X-ray plate, is water view. If forehead is touching X-ray plate, it is the cardival view. If chin is touching X-ray plate, it is water view. If forehead is touching X-ray plate, it is cardival view. All of you look at me. How we drink water. Everybody look at me, beta. How we drink, look at me, beta. How we drink water like this. So chin touching X-ray plate is water view. Card well. How you look in the well like this. Forehead touching X-ray plate is the cardival view. Beta. Cardival view. Okay. There are four view, beta. Four view. Look at screen. I put on the Instagram also the same thing. Chin touching X-ray plate, water view. Okay, clear. Forehead touching X-ray plate, cardival view. Okay, great. Now, Let's do the reverse bit. If your occiput is touching the X-ray plate, it's Townie's view. Townie. Occiput, this one, right? Townie's view. It's for the mastoid. Okay. And if patient is lying on Schuler, Shoja, Schuler, Soja, Soja, Schuler, Soja, sleep, Schuler, sleep. If somebody is lying ear touching the X-ray plate, is the Schuler view. Is it difficult? Beta? We make things too difficult. There. Let me tell you, if chin touch the X-ray plate, drink the water. If forehead touch X-ray plate, look into the well, cardable view. Beta. If occiput touch the X-ray plate, go to the town. Beta. Go to the towns facing forward, Townie's view. If you're sleeping, beta, ear touching X-ray plate, it is Schuller's view. Beta. Schuller's view. Okay. Could you relate to this, beta? Could you relate to these tricks or no? Tell me. I want you to excel in the exam. And the excellence in the exam is not just cramming. How would you recall that data? I want to understand. Could you really, because this is actually havoc for people, beta. But if you know the logic, how to solve that question, you're able to crack, oh, which view is which view, beta. Okay. All these are on the Instagram also, beta. Okay. Now, next one, beta. I would not take too much of your time. I know your time is very precious. I will touch upon the main point of this 25 question and those concepts also. To reiterate my time with which we are spending together, please comment in the chat box. Is it useful for you or not? Tell me, because be very clear and be very utterly honest with them. Because idea is to give you a premium. That's what the thing is. More clarity, more confidence. The premium confusing topics actually. Toss class with Sade, fish, like Redkowski and these X-rays and all. They are the one which decide your rank because you're not clear. That's why like next one. Next. So this is again a very important domain. But all of you touch the center of your nose. This is the dorsum of your nose. The support comes from septum. If septum has a perforation, there will be a depression in the center of the nose. That's called depressed nose. It's called saddle nose. This is saddle nose. This time, again, the question came of septal perforation on NEET PG. And this is the septal perforation. Septal perf. So septal perforation with saddle nose deformity, they are put together. Okay. Now, what are the causes of these two situations? Number one, trauma. Number two, septal surgery. Which two surgery? Remember, septoplasty and SMR surgery, submucosal resection. Okay. Cocaine is a vasoconstrictor. Chronic diseases like TB, lupus, leprosy, they cause perforation of cartilaginous part. Syphilis cause perforation of bony part. That's very important. And vaginal granulomatosis cause perforation of both parts. So TB, lupus, leprosy cause perforation of cartilaginous part of septum. Tertiary syphilis cause bony part of perforation, that's MCQ, and vaginal cause perforation of both parts. Okay, fine. Now, in perforation, what is symptom? Crusting. This time, NEET PG, they said perforation picture was there. Crusting in the nose, the main symptom, perforation, and outside shape deformity called saddle nose deformity. What we do, we take biopsy from here and send for histopathology examination from the edge of the perforation. If this shows caseous necrosis, it is tuberculosis. And if this biopsy report is necrotizing vasculitis, of course, it is vaginal granulomatosis. If it is caseous necrosis, it is, of course, the tuberculosis. If it is necrotizing vasculitis, it is vaginal granulomatosis. Now, biopsy from the nose has revealed the necrotizing vasculitis. Answer is vaginal. They might ask you, what is the other thing you do? CNCA testing. CNCA. Get engaged, but everybody get engaged and keep answering the question with us. Get engaged. Okay, CNCA testing. Okay, CNCA. Everybody, please comment. Are you seriously preparing for INICET and in the upcoming NEET PG also? Be very serious. This is a very, very crucial juncture of your life with us. Please be fully devoted. Okay, don't do half-hearted stuff with us. Now, let me tell you one secret with us. If your exam anytime has this question, hemoptysis plus epistaxis. There can be many causes, Goodpasture syndrome and whatnot. But first and most likely possibility is vaginal granulomatosis. I'm not saying Goodpasture syndrome is not possible and all that. I'm saying that most likely autoimmune disorder to involve the nose is vaginal granulomatosis. In vaginal granulomatosis, the commonest ENT manifestation is sinusitis-like symptom. The commonest presentation of vaginal granulomatosis in ENT is sinusitis-like symptom. If you ever get hemoptysis patient with the epistaxis, please think of vaginal granulomatosis. This is a clear-cut rank deciding scenario. Okay, other are possible, but most likely, most common vaginal split. Everyone, let's go together further. Newborn baby is having cyanotic spell at birth. Cyanotic spell at birth with difficulty in breathing, and the symptom improve with crying. I think you know. Some question will be like that. The symptom improve with crying. You already know the answer. It's a case of bilateral complete choanal atresia. What is the urgent priority? First of all, choanal atresia is an embryological disorder due to persistence of bucco-nasal membrane. It can be unilateral. Don't forget to revise Charge syndrome. Charge syndrome is already there. Me and Sandeep sir have put one video also in the doctoral channel also. Unilateral, still okay. Okay, this is open, na? No problem. But problem is bilateral. Oh, both sides, bilateral. Bilateral complete choanal atresia is a neonatal airway emergency. Why? Because neonates are obligatory nasal breather. First question. Why bilateral complete choanal atresia is a neonatal airway emergency? Because neonates are obligatory nasal breathers. Now, because if I close your nose, we will not die, beta. We open mouth and survive. But baby is newborn, just landed on the planet. He does not know the trick, beta. But the moment baby opens mouth to cry, baby gets pink. Blue baby turns pink on crying, beta. So the chief complaint will be clinical scenario, beta. A newborn baby having respiratory difficulty and cyanosis at birth, but the condition dramatically improves on crying. Any cyanosis appearing in crying is a direct clue for choanal atresia question, beta. Okay, fine. And pediatrician people call it cyclical cyanosis. Cyclical cyanosis over there, cyclical. Now, pediatrician would do what? He will put a wide bore nipple or oropharyngeal airway in the mouth of the baby and tie it with the gauze piece, beta. It is called McGovern's technique. McGovern technique, beta. McGovern's technique, beta. McGovern's technique, beta. Okay, fine. Put a wide bore nipple or oropharyngeal airway to save the baby. McGovern technique is a life-saving technique. Then you do the intubation, then you do tracheostomy and let the child grow for 1 year. And then ENT people will do recanalization surgery. We'll make a hole over there. And anybody, which drug I must apply on the edge of this hole so that it does not get restenosis? Yes, the answer is mitomycin C. Mitomycin C. Everybody, mitomycin C. Mitomycin C. Very good. Next one. So the answer to this question will be, of course, let me tell you the answer. The answer to this question was McGovern technique. I hope I've told you a previous answer also. So this question is vaginals. This X-ray question was definitely Caldwell view. This is Caldwell view. Question number 10, somebody is asking answer, Caldwell view. Okay, fine. Now, allow me to go further. Everyone, this one. 2-year, 3 months old child is brought to the hospital with sudden bout of cough and breathing difficulty. These questions are coming more in INCET NEET PG. Why? Because it's emergency scenario based question. You are the intern, you're the first contact person for this patient. Okay, there is no other history given by the parents. What is the best initial management strategy for this patient? You are the hospital medical intern in the emergency. Child has come who is 2 year, 3 months old, and there is sudden bout of cough and there is breathing difficulty. Guys, this can be what? Foreign body larynx, foreign body bronchus, foreign body trachea, and it cannot be foreign body esophagus. But why? Foreign body esophagus. First of all, foreign body esophagus will lead to dysphagia and throat pain, not dyspnea. Foreign body esophagus will lead to dysphagia and throat pain. You remember this? The coin story. I hope you remember surgery, medicine, surgery, radiology would have done. Full coin. Very easy way to remember. O for esophagus. If you see full coin on the front X-ray, O or esophagus, on the lateral view, edge of the coin. Tracheal foreign body, tracheal foreign body. If you see the edge of the coin like that, okay, fine. Just imagine one more line over that. T for trachea. T for trachea. Are you getting about how to make this easy in the exam? Confidently easy. Ultra high scoring, not like backdoor things, over there. In the exam, O is there, esophagus. Esophageal foreign body will have dysphagia, throat pain suddenly starting in a normal child who was playing with the toys and all. Tracheal foreign body would be ultra high emergency like laryngeal foreign body. In tracheal foreign body, cough is not there. It's more of choking feeling. Tracheal foreign body, higher the foreign body, more dangerous it is. Tracheal foreign body, why it can't be? They ask you most likely scenario. Na? Tracheal foreign body will have more severe, grave choking. One. Number two, no cough. Number three, there is a special finding called palpatory thud. Palpatory thud means if you keep a finger over here on the trachea, the tuck, 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 touching, dancing in the trachea. So that can be tracheal foreign body. It's very uncommon to have tracheal foreign body. It's a pipe and the foreign body fall down mostly. They find that's why it's uncommon. Now, so what it is then? Now, this is what? Can be foreign body larynx? Not at all. Why? Laryngeal foreign body will typically have what? Choking while eating. No cough again. Choking and aphonia. Choking and aphonia while eating. That is laryngeal foreign body. My dear friend, this sudden dysphagia, throat pain while playing, esophageal foreign body. Front, full coin. Again choking, and palpatory thud over there, no cough, the tracheal foreign body. Okay. But choking while eating, most commonly due to laryngeal foreign body, and you do Heimlich maneuver, you press the epigastrium. My dear friend, this is the case of foreign body bronchus. Foreign body bronchus is the most common foreign bodies are peanuts. Peanuts. Right foreign body more than the left. The right is more common than the left. You fine? So bronchial foreign body are more common on the right side as well as the left side. You all know that right bronchus is wider and right bronchus is more in line with trachea. Most common foreign body are peanuts. Peanuts. Why? There are parents, the nuclear parents now, metro city couples and all that. They have a 2-year-old child. Weekend is there. They switch on the television, Netflix movie, some beer, some wine, some bhujia, chakna, vakna, whatever. Some bhujia they give to the child also. And one in the bhujia, there are peanuts. 2-year-old child, 1-year-old child cannot crush the peanut. He inhales the peanut by chance. That's why I always say, promises and babies. Promises and babies are easy to make, difficult to deliver. Promises and babies are easy to make, difficult to deliver. Okay. Now this went inside. Sudden cough started. What happened? What happened? This is your trachea. This is your right and left bronchus. This is, my dear friend, peanut over there. Peanut over there. And now the air cannot do. Our immediate management will be, intern should do what? X-ray chest. X-ray chest. Answer to this question is urgent X-ray chest. We can't plan a procedure just like that, we have to see where it is. And patient is not dying. It's not choking patient. Okay, fine. Cough and breathlessness. Okay, fine. Now, everybody please see. The number one finding is collapse. This is collapse. Number two, it can be hyperinflation of lung. Why? Because some foreign body, what do they do? They allow the entry of air, but they don't allow the exit of air. So collapse is number one finding. Number two, hyperinflation. Number three, it can be just normal X-ray. Maybe it's a small, this thing, peanut. It's irritating, but air is going and coming out properly. Okay, fine. So it can be collapse, hyperinflation, or normal X-ray. Treatment is urgent, rigid bronchoscopy. Don't write flexible. Urgent, rigid bronchoscopy. Urgent, rigid bronchoscopy and removal. Don't write flexible over there. Please. Rigid bronchoscopy will give you same channel for the oxygenation of the baby because patient is under general anesthesia. Okay, fine. Now, so what is the answer to this question? Urgent X-ray chest. Most probably it's the right bronchial foreign body, and we plan for urgent rigid bronchoscopy. You can't plan the bronchoscopy without X-ray. You have to know where it is. Heimlich is for laryngeal foreign body. Okay. Why to intubate? Why to intubate? There's a cough, breathing difficulty, and all that. Okay, fine. I hope it's clear to everybody. Foreign body nose, Foreign body nose is more common in school age children. School age children, School age children. They put something in the nose and the foreign bodies. You remember in your school days, we used to rotate the eraser in the nose. Some students used to erase. Teacher will slap. What are you doing? Eraser left in the nose only. After 2-3 weeks, this eraser get infected. From infected foreign body, the smell come, the blood come, the pus come, the same question come. What is the question? Write down. The question is 7-year-old child presenting with unilateral foul smelling nasal discharge. Moment you see unilateral foul smell from the nose of the child, it's a foreign body question. It's a foreign body question. And I think you remember battery, double ring sign. Nobody can forget double ring. Such a popular question. Coin versus battery. Battery is double, battery double. Battery, coin in the esophagus is not emergency. Battery in the esophagus is emergency. ऐसा नहीं कि बैटरी से बच्चा स्टार्ट हो जाएगा बेटा, नॉट लाइक दैट बेटा. बेटा child will not get activated because battery release alkali, and that alkali can lead to esophageal perforation. Coin in esophagus is not an emergency, but battery in esophagus is definitely an emergency. Double ring sign, and patient must be taken for urgent rigid esophagoscopy and removal. Now, question number 14, you know E. coli ma, very very important. Okay, don't forget to revise E. coli ma story. Auditory pathway. Okay. Now, E for eighth nerve. They play the things with you. Eighth nerve, they never wrote. Spiral ganglion is the beginning of eighth nerve. This is E, beta. This is E. Okay, E. Cochlear nucleus is there, beta. So look at this D, then E, cochlear nucleus, then A, okay, olivary complex superior, then C, lateral meniscus, and I, inferior colliculus. These questions can go wrong if you don't know spiral ganglion is nothing but beginning of the eighth nerve. Spiral ganglion lies in the modulus of cochlea. The central axis of cochlea contains the spiral ganglion of the eighth nerve. Okay, this is the important thing. I want to tell you a couple of more things. Now, in the E. coli ma, there are three more questions of auditory physiology for INI CET. First of all, sound localization. Sound localization. Number two, cross over of impulses. If you do that, my both cortex of auditory system are activated. Number three, stapedial reflex. Stapedial reflex. Going to contralateral side. Contralateral. If I give loud sound to this ear, both stapedials contract. All these three things occur at olivary complex superior. Superior olivary complex. These are three auditory physiology rank deciding questions. Sound localization, crossover of the impulses, contralateral stimulation of the other auditory cortex, and the stapedial reflex. One ear, if you give loud sound, both stapedial muscle contract. All these three crossover information are occurring at superior olivary complex. Don't forget this. Now, cochlea is organ of Corti, and organ of Corti has got two type of hair cells. So these three are outer hair cells, and these are inner hair cells. Now, outer are 3 times more than inner in number. Outer are flask shape. Outer are cylindrical, and inner are flask shape. Most importantly, outer are efferent, inner are afferent. Outer are efferent, inner are afferent. Okay. Now, outer control the inner hair cell. Outer control the inner hair cell, and inner hair cell, they're afferent. They produce action potential in 8 nerve fibers. Once again, beta, please see outer hair cell versus inner hair cells. They are 3 times more than inner in number. Outer are cylindrical, inner are flask shaped. Outer are efferent, inner are afferent. Outer control inner hair cells, and inner hair cell produce action potential in 8th nerve fibers. This is a confusing point for people. How to remember it? Please see inner hair cell. What is this, beta? What is this? This is number 1. What is this, beta? This is, of course, the number 1. What is the first alphabet of A, B, C, D, beta? A for alphabet. How would I recall this on the exam table? What is I, beta? This is what number 1. What is the first alphabet of A, B, C, D? A. A is what, beta? Afferent. That will be efferent. Are you okay, beta? Fine, everybody? Everybody okay? Everyone okay? Please comment. Are you there with me? Everyone, are you okay? Are you there? Sure. Yes. Sure. Next one, beta. In the given condition, which of the following statement is true? Now, first of all, what is this, beta? Is it glue ear? When you see air bubble behind tympanic membrane, think of glue ear. This is glue ear. That's a glue ear. The air bubble behind tympanic membrane is glue ear. Now, number 1. The glue ear, the other name is serous otitis media, also called otitis media with effusion. Serous otitis media or otitis media with the effusion. Okay, fine. Now, please see. It is more common in school age children. Okay. And the most common cause is adrenal hypertrophy. Adrenal hypertrophy, everybody please understand that whenever you have a mouth breathing child with hearing loss, diagnosis is very clear. Adenoid hypertrophy with glue ear. Whenever you have a mouth breathing child like this with hearing loss, the diagnosis is adrenal hypertrophy with glue ear. Okay, to fine. Now, I hope you remember glue ear is not painful. In glue ear, the pain is not there. It's only heaviness in the ear. Heaviness and conductive hearing loss. Parents will say he keeps the television volume high during surgery, during watching cartoons. He keeps the television volume high during watching cartoons. Okay. Teacher will say poor school performance. Poor school performance. Tell the teacher to make the child sit in the first row in the class. And this will lead to conductive hearing loss because glue ear is the middle ear problem. Fine. Now, look at screen, please see. First, which of following is true? SNHL is common feature. No, it's conductive hearing loss. Red tympanic membrane, not at all. Red is a feature of ASOM. This is retracted tympanic membrane with glue in the middle ear with air bubble trapped in the glue. My dear friend, it's a retracted tympanic membrane with the glue in the middle ear with the air bubble trapped in the glue. Now, ear ache is a common symptom. No, not at all. It's only heaviness. Tympanosphere tubes are usually required for treatment. Yes, this is equal to grommet. The best treatment of this patient will be what? Number one surgery is adenodectomy. Adenodectomy, and the best method of adenodectomy is coblation nowadays. But don't forget about coblation. Coblation is the best method of adenodectomy. Number two, plus maryngotomy and grommet insertion. Please remember maryngotomy. This is the grommet. G for glue, G for grommet. We put grommet in the tympanic membrane. Okay. And it we put in the antero-inferior quadrant. In the antero-inferior quadrant. Okay. So maryngotomy plus grommet insertion. Plus, don't forget adenodectomy. Adenodectomy. My dear friend, adults don't have adenoid. Adenoid disable by 20 years of age. Now, my dear friend, this is the Eustachian tube opening, and this is fossa of Rosenmuller. Don't forget fossa Rosenmuller. Now, Eustachian tube opening, this bulge is called TT, torus tuberous. Eustachian tube is a naturally closed tube. Okay. And there is a pad called Ostman's pad of fat. Remember this MCQ, but Ostman pad of fat is around the Eustachian tube opening to keep it closed. Ostman pad of fat is found where? In the Eustachian tube to keep it closed. Which muscle open the Eustachian tube? Tensor villi palatini muscle. Tensor villi palatini muscle opens the tube. Now, fossa of Rosenmuller is site of origin of which cancer? Anybody? Which cancer? Which cancer? Nasopharyngeal carcinoma. And this will block the Eustachian tube. This is nasopharyngeal carcinoma, which is caused by Epstein-Barr virus. And age of the patient is 50 to 70 years. 50 to 70 years. So if the 50 to 70-year adult patient develop glue ear, it's a breaking news. A child getting glue ear is a normal, common disease. Because adenoid are there, but adenoid disappear by 20 years. 50, 60, 70-year adult getting unilateral glue ear question is a breaking news. It's a suspected case of nasopharyngeal carcinoma. My dear friend, NPC is a hidden cancer behind the nose. That's the nasopharyngeal carcinoma. And most common presentation is metastatic cervical lymphadenopathy. Number two is the unilateral conductive hearing loss due to glue ear. Number three is the cranial nerve involvement, which lead to Trotter's triad, famous triad, Trotter's triad of NPC. NPC. Mnemonic also NPC. N for neuralgia in temporoparietal area due to fifth nerve involvement. P for palatal paralysis due to 10th nerve involvement. And C for conductive hearing loss due to glue ear. And treatment of choices, first of all, it's a hidden cancer. Very easily missed. That's why 50, 60, 70-year adult getting unilateral glue ear, please mark the answer, nasopharyngeal carcinoma patient. Mouth breathing child with hearing loss, adrenal hypertrophy with glue ear. 50, 70-year adult patient, unilateral glue ear. Answer is nasopharyngeal carcinoma. Nasopharyngeal carcinoma, my dear friends. Okay. Now, let us do two questions, better. Your exam question. 6-year-old school child presented with hearing loss. Oh, 6-year-old child, hearing loss is there. And high arch palate, crowding of upper teeth, beta. This is a feature of adrenal hypertrophy. Adrenal will have two symptoms, beta. Mouth breathing child with some dental problem. Mouth breathing child with dental alignment issue, malocclusion, crowding of upper teeth. That's adrenal. Tympanometry was done, and this is type B tympanogram. Type B or flat tympanogram is a feature of glue ear, beta. So this is a case of adrenal hypertrophy plus glue ear. If you mark A choice, it's a wrong answer. It's a half treatment, beta. Half treatment. If you mark D choice, it's a wrong answer again. It's again a half treatment. The correct answer will be C. Are you getting my point, beta? Why we are losing marks in the real paper, beta? Why? Sometimes we get carried away with the A. Oh wow, glue ear, grommet, मजा आ गया. मजा तो आया, नंबर नहीं आया बेटा. मजा तो बहुत आया, नंबर नहीं है, नंबर नेगेटिव आ गए. है ना? Read all the four choices carefully. Two surgeries, beta. Okay? Are you able to relate to this? Beta? This kind of mistake happen. Question number 16. 52-year-old adult patient, again presenting with right-sided hearing loss, which is diagnosed to be case of right-side cirrhosis media. My dear friend, child getting glue ear is a common phenomenon. 50-year adult getting once unilateral glue ear, 50-year adult getting unilateral glue ear. What would you mark the answer, anybody? What would you mark the answer, anyone? What would you mark? Don't write grommet. Grommet is not my priority here, beta. My priority is nasopharyngeal carcinoma. Rule out that. It's a hidden cancer. It's a hidden cancer behind it's right behind the nose, beta. First of all, put an endoscope and take a biopsy from there. So the answer to this question is A. Nasopharyngoscopy and biopsy. This is a very highly likely question, beta. Don't write grommet in session. Are you able to learn from this session? My only humble attempt is to make sure that your time is not wasted. Everybody, are you there? Are you able to see how you're doing mistake in the paper? Beta? Like this is a classic example of mistake. This we might get carried with grommet insertion. That's the later on phenomenon. First of all, let us rule out the nasopharyngeal carcinoma. Nasopharyngeal carcinoma. Okay, very good. Next one, beta. Superior semicircular canal Tyson syndrome. Beta. It's a new phenomenon, relatively now. This is an opening over here. On the CT scan, you can see that in the superior canal. Unfortunately, the sound energy is leaking from here, which lead to conductive hearing loss. My dear friend, cochlea is normal. So no SNHL in this case. No SNHL in this case. Okay? Cochlea is normal. This patient has got conductive hearing loss due to loss of sound energy from this dissonance. And this is called third window phenomenon. Third window phenomenon. Why? Nature gave us two windows, oval window, round window. But another window got created, the third window phenomenon, conductive hearing loss. Okay, fine. So in this case, please see, beta. Third window phenomenon, yes. The Tullius phenomenon, yes, beta. Why? Tullio phenomenon is vertigo on hearing loud sound. Vertigo on hearing loud sound. Beta. Vertigo on hearing loud sound is Tullius phenomenon. Beta. Tullius phenomenon. Vertigo on hearing loud sound, Tullius phenomenon. And HRCT is helpful, yes. Plus vestibular evoked marginal potential also. SNHL is not there. It's conductive hearing loss. Conductive hearing loss. My dear friends, CT scan is shown better. This is the superior canal dehiscence opening over there. Fine. What is VAMP? Vestibular evoked marginal potential is INCT question. Please see. First of all, you give sound to the stimulus saccule. Saccule. Okay. And you record the electrical activity in sternocleidomastoid muscle. Please look at the name. Look at the name VAMP. Vestibular evoked marginal potential. What is vestibule? Saccule. What is myogenic? Sternocleidomastoid muscle. So VAMP is a test of saccule, first of all. VAMP tests saccule. And number two, VAMP is a test of inferior vestibular division of 8 nerve. VAMP is a test of saccule and inferior vestibular division of the 8 nerve. Guys, let me tell you a few phenomena. First of all, the recruitment phenomenon means Loud sound appear more loud. Abnormal perception of loudness. It's a feature of Meniere's. When I say Meniere disease, is cochlear. Number two, beta. Tullio's phenomenon means vertigo on hearing loud sound. It is seen in Meniere disease and superior semicircular Dyson syndrome. Number three, beta. Number three is third window phenomenon is seen in superior canal Dyson syndrome. Beta. Number four, rollover phenomenon is a feature of acoustic neuroma. Rollover means when other person raises the intensity of sound, your understanding falls further. Rollover, you roll over. Beta. Fine. Rollover phenomenon is a feature of acoustic neuroma. Fourth phenomenon. Recruitment phenomenon, Meniere's disease. Tullio's phenomenon, Meniere disease and superior canal Dyson syndrome. Third window phenomenon, superior canal Dyson. Rollover phenomenon, acoustic neuroma. Acoustic neuroma. Fluctuating hearing loss. Fluctuating hearing loss is Meniere's disease. Meniere's disease. Okay. Diplecusis is a feature of Meniere disease. Paracusis willisii is otosclerosis. Diplecusis, Meniere disease. Paracusis willisii, otosclerosis. Now, hyperacusis is a feature of Bell's palsy. Bell's palsy. And presbycusis, age-related hearing loss. Diplecusis, Meniere disease. Paracusis willisii, otosclerosis. Hyperacusis, feature of Bell's palsy. Now, again, all are following a smell perception test except. This is important now, post-COVID, except. The best test of olfaction is UPSIT. What is UPSIT? The University of Pennsylvania Smell Identification Test is the best test for olfaction nowadays. The other tests are the CCSIT, cross culture. UPSIT is more detailed test because all smell agents are not known to every person in the world. Cross culture means there are some smells, some aromatic agents which are universally available. You can use that. The limited version of this is CCSIT. Okay. And number three is smell diskettes. Smell diskettes. Okay, fine. But in this case, this is yes, this is yes, this is yes. Saccharine test is for the ciliary function. Nasal cilia. Everybody, ciliary function, all of you please see. Nasal cilia move backward. Nasal cilia move backward at the speed of, like 10 to 20 beats per second. How to test the ciliary function? The ciliary function test is number one is the saccharine test. Saccharine test. Please see, you put a drop of saccharine here. After how many minutes it go to your throat taste? Number two, charcoal test. Charcoal test, put a suit of charcoal here. After how many minutes the black suit goes in the throat? Number three, gamma scintigraphy. Same charcoal, but with radio labeled particles. Okay, and you do gamma scan after a few minutes to see the throat, the particle reach or not. But electron microscopy is not for the functional evaluation of cilia. Electron microscopy is for the structural evaluation of cilia. You must have heard the name Young syndrome, Carter syndrome. These tests are used there. So I repeat, saccharine test, charcoal test, gamma scintigraphy are for the functional evaluation of cilia. Electron microscopy is for the structural evaluation of cilia. Now, question number 19. This is again a favorite domain. Any turbinate hanging from the roof, it's mild turbinate. Mild turbinate. If the middle turbinate, this is septum. Septum. This is middle meatus. Middle meatus. Now, my dear friends, look at this one. S is septum. S is septum. This is lateral wall of nose. That's the middle turbinate. That's the middle. Any turbinate hanging from the roof is middle turbinate. Turbinate starting from the side is inferior turbinate. And this is inferior meatus. Inferior meatus. Inferior turbinate, inferior meatus. Okay, everybody, please see. This picture I already gave and people got confused. Is this inferior turbinate or this inferior turbinate? My dear friend, please understand, this cannot be inferior turbinate, Turbinate will have some space below that. This space, meatus is there, This is only septum which is deviated like this. Is a DNS only, This DNS, that is septum. Don't get confused. This is inferior turbinate is the answer of this question, That middle turbinate. This is the middle turbinate. That's the middle turbinate. And that's the middle meatus. Middle meatus. Okay, fine. Look at this one, So this answer to this question will be middle turbinate. Middle turbinate is the answer. Okay, fine. Next one, Once again, this is likely question, This is your which turbinate? Middle turbinate. Which meatus? Middle meatus. This largest cell in middle turbinate is bulla ethmoidalis. This is bulla, and this process is uncinate process. Bulla and uncinate process. Bulla and uncinate process. Bulla ethmoidalis is the largest cell of ethmoid in the middle meatus and covered by uncinate process, sickle shaped bone. Okay, now radiology is asked in nose, beta, X-ray, cardival view, water view, CT scan, beta. Please see. This is what is ethmoid? It's a single bone between two orbits. My dear friend, this is orbit and this is ethmoid bone. The largest cell in the ethmoid is called BE, beta. What is BE? Bulla ethmoidalis. My dear friend, what is concha bullosa? A cell in the middle turbinate. My dear friend, this is maxillary sinus. That's the inferior turbinate. And this is the middle turbinate, beta. This star is the concha bullosa. When you see a cell in the middle turbinate is concha bullosa. Beta. Everybody, this is next one. Beta. Agar nazi is the anterior podia cell. Agar means the aage. This is the axial CT. Beta. This is orbit. This whole is the ethmoid bone. And these all are ethmoid air cell. Beta. Ethmoid air cell. And the frontmost cell is the agar nazi. Agar nazi is anterior-most cell. And a cell in the floor of the turbinate, orbit. A cell in the floor of orbit is called Heller cell. Anybody, what is this? I want everyone to comment. I want everyone to comment. What is this white arrow? What is this white arrow? Please comment below. What is this white arrow? What is this white arrow, everyone? Anyone? What is this white arrow? This white arrow is what? Concha bullosa. Yellow arrow is Heller cell. This middle turbinate, na? The yellow arrow is concha. The yellow arrow is the Heller cell, and the white arrow is the concha bullosa. Concha bullosa. Very good. Concha bullosa. Radiology of the sinus is very, very important for both exams. Now, this was asked in the INI CET. Now, this was something very strange. They should not have asked you guys, but they've asked it. It can be repeated. Now, what is this? This is CT of the sinus, X-ray of the sinus will be there 1 or 2 questions in the INI CET. It is like that only. Something CT or story of maxillary sinus cancer, ethmoid, some inverted papilloma CT, etc. will be there. Don't get scared of all that. My dear friends, this is a rare anatomical variation. This is the pneumatized superior turbinate. My dear friend, this is the inferior turbinate, middle turbinate. This is the superior turbinate. This is the superior turbinate. There is cell in that. I'll put a dot here. This is the pneumatized middle turbinate. Pneumatized middle turbinate is the PYQ of the INI CET. Now this one, again they ask this one to you guys. They should never ask. This is the anterior ethmoidal canal. Anterior ethmoidal canal for the anterior ethmoidal artery. The anterior ethmoidal canal for the anterior ethmoidal artery. If they ever show you arrows like this, both sides, it's anterior ethmoidal canal for anterior ethmoidal artery. This artery coming from orbit to the nose. If it is damaged during the FES surgery, there will be orbital hematoma. Orbital hematoma after surgery. So your applied anatomy question on the base of this canal. If patient develop big orbital hematoma after FES surgery, which artery is the culprit? The artery is anterior ethmoidal artery, and this is the anterior ethmoidal canal over there. These two are rare CTs. One is the pneumatized middle turbinate, other is the anterior ethmoidal canal. But we have to keep in mind, already asked over there. Audiogram. Interpret the audiogram given the picture. Audiogram, favorite topic. Now, first of all, red lines are for right ear and blue lines for the left ear. Okay, blue lines for the left ear. So anything above 25 is normal. We know that. So right is normal in this case, and left has got SNHL. And there is a rising pattern of audiogram. The answer to this question will be Meniere disease. Meniere. Very, very, very important question. Meniere. Dr. Dhawan, why it is Meniere? Number one, Meniere is a unilateral disease. Dr. Dhawan, how would I remember it? How would I remember it? Just make a story in your mind the way I remembered in my MBBS days. M for Meniere, M for migraine. M for Meniere, M for migraine. Migraine is also one-side headache, and migraine is episodic. This is also better. This is also like that. This is also like that. M for migraine, M for Meniere. Just like migraine, Meniere also single-sided and episodic. Better. Dr. Dhawan, okay, one side is normal, right is normal, left is SNHL. But why ascending pattern? Better? Why rising pattern? Better? Because One, okay, one cochlea is normal, other is damaged. And the damage of cochlea in mean years start from apex. And I hope you remember, in the basal turn, we say here the 8,000 hertz. And at apex, we hear the low frequency, 250 hertz. In this case, 250 is more affected, 8,000 is normal. Do you see? 250 is why? Apex of cochlea is more damaged. 250 is more affected, and 8,000 is normal. So that's a rising audiogram. Rising audiogram. Why it is not pressed bicuspid, sir? Pressed bicuspid will have bilateral sloping hearing loss. Please see. Let me show you. Pressed bicuspid. Please see. Mean ears rising. Pressed bicuspid is what? Pressed bicuspid is age-related hearing loss. Mean ear involve one ear. One ear. Age involve both ears. Mean ear involves the apex first. Age involves the basal turn first. Basal turn first. Mean ear is rising. Mean ear, rising. Mean rising. Age is sloping down. Please see. Can you see both ear are coming down but sloping? Is it understandable, Bache? Tell me. Mean ear involve one ear. Other ear is rising audiogram. Age involve both ears sloping audiogram. Bilateral sloping SNHL. Bilateral sloping down SNHL. Age is sloping you down, Bache. Now, two dips. Very famous question every time there, otosclerosis. Otosclerosis is conductive hearing loss. This is bone conduction curve. Upper line of always bone conduction. Whenever you see AB gap, AB gap is conductive hearing loss, and otosclerosis is conductive hearing loss. Conductive hearing loss means AB gap. And Carhart's notch is a dip at 2000 hertz in bone conduction curve. Carhart's notch is a dip at 2000 hertz in bone conduction curve. This is the audiogram asked most commonly. Acoustic dip in noise-induced hearing loss, occupational hazard, textile industry worker, some occupational hazard is there. Its dip is at 4,000 hertz in AC/BC both. So guys, please see, if the dip at 2,000 hertz in BC, it's otosclerosis. Carhart's notch. Dip at 4,000 hertz in AC/BC, it's acoustic dip. Fine. Now, let's please see. This is normal. This is conductive hearing loss, AB gap, and SNHL, both AC/BC. Please understand, but 7 audiogram to be kept in mind. If both lines are about 25, normal. If there is AB gap, conductive, and if they both AC/BC are poor, it's SNHL. If there 2,000 hertz dip in bone conduction with conductive loss, it's otosclerosis. 4,000 hertz dip, noise hearing loss, acoustic dip. Mean ears, one ear normal, other ear SNHL, rising audiogram. Okay? Pressed bicuspid, sloping audiogram, sloping SNHL, bilateral, both sides. Are you able to relate to this? Ask me. So everything has a unique finding. Answer is mean ear disease. Mean ears. Let us do the INCET question. Patient is not able to hear properly from the left ear. Same audiogram there. But this time they did not ask diagnosis better. They asked, compare this with tuning fork finding. So it's a left SNHL. Right is normal. Left SNHL, right is normal. Okay. So what is the tuning fork finding? Please see. In SNHL, Rene will be positive. So Rene will be positive. Where the Rene is positive? So left Rene positive is here. Okay, fine. Let's talk about right side. Right is normal. Rene will be positive. Rene will be positive. Okay. So right Rene positive, right Rene positive. So this choice is ruled out. Okay. Now, in SNHL, Weber always goes to the better side. Right is the better, na? Right is better. Right is normal here. So basically saying that Weber should be in the right ear. Okay. So Rene is positive on the right side and Weber is lateralized to the right. That's the answer. That's answer. He never mentioned about left ear, beta. Could you understand this one, beta? Left SNHL, Rene should have been positive. Right normal, Rene should have been positive. But in SNHL, Weber always lateralized to the better ear. Right is the better ear. So only those answers are relevant, beta. Weber is lateralized to the right ear in this case. This is wrong. This is also wrong. So you have to choose between A and D, beta. A is anyway wrong, beta. Left side Rene is not negative. Left Rene is positive, beta. Could you understand this? Tell me. Are you able to understand better this one? D is the answer, beta. D is the answer, everyone. Now, 70-year-old male patient underwent tonsillectomy on Monday. His post-operative period was uneventful. Discharged next day on Sunday morning. Operated for Monday, Sunday morning. He presented in an emergency department with a history of mild bleeding for moral cavity. My dear friend, this is a typical case of secondary hemorrhage. Secondary hemorrhage after tonsillectomy. This is due to infection of tonsillar fossa, and treatment is admission and antibiotics. Let's quickly revise the hemorrhage in tonsillectomy. Hemorrhage in tonsillectomy three types. The primary hemorrhage is during surgery in the operation theater, and the source of bleeding is paratonsillar vein, your exam question. Secondary, reactionary beta. Reactionary hemorrhage in the ward within 24-hour surgery. It is due to slippage of ligature. It is severe bleeding. So it's an emergency. Treatment is urgent re-exploration. R for reactionary, R for re-exploration. What is your role as intern? I will do the re-exploration. Your role as intern is, your role as an intern is start IV fluid and arrange blood transfusion. They can ask you like this, but my role is re-exploration. But they're asking question to an intern. They will ask you, what is your role? Arrange blood transfusion and start IV fluid over there. Okay, fine. Now, secondary hemorrhage after 5 days, late hemorrhage in home, patient was given something to eat. Typical history will be child gave chips to the mother to eat. That led to infection in tonsillar fossa, and mild bleeding. Treatment is intravenous antibiotic. So this is surgery done on Monday. Bleeding started on Sunday. It's a mild bleeding. They will give you a story. Mother gave biryani, rice, nachos, or chips to the baby after surgery, and there's a pain now, throat pain, minimal bleeding starting. It's not a very big bleeding. Treatment is admission and antibiotics. But now, oropharyngeal picture shown in the image of a patient presents with trismus, plummy voice, dysphagia, and fluctuating swelling near angle of mandible following dental extraction. Moment dental extraction come, people say, wow, maza aa gaya, Ludwig angina. But that's incorrect answer. Ludwig angina is not swelling near angle of mandible. Ludwig is the swelling below the chin. Below the chin. The answer to the question is parapharyngeal abscess. Parapharyngeal. Look at me, buddy. Please see, dental infection can cause 2 MCQs, beta. Please see, this is your mandible. This is your mandible. Molar, premolar. If the teeth got caries and chin swelling happen with the trismus, that's Ludwig angina. But if swelling went this way and this swelling close to angle of mandible, a lateral neck swelling close to angle of mandible or close to sternocleidomastoid, it is parapharyngeal abscess. Parapharyngeal abscess is very much similar to quinsy. Because parapharyngeal abscess also, you see, parapharyngeal abscess also, the uvula is pushed to other side, tonsil is pushed medially, there's a trismus, plummy voice, everything same with that. But there's outer neck swelling also given. My dear friend, in quinsy, the outer neck is normal. Neck in quinsy is normal. No outer neck swelling. No outer neck swelling in quinsy. Internal picture is absolutely same, bache. Why it is not quinsy? Please see, beta, please see. Uvula is pushed to other side, tonsil is pushed medially, there's trismus, plummy voice, everything is in there. But quinsy does not have outer neck swelling, beta. If quinsy-like question is there, along with that, there's a lateral neck swelling. The answer is parapharyngeal abscess. Why it's not Quincke? Quincke is something else, my dear friend. Quincke is idiopathic angioneurotic edema of uvula. Idiopathic angioneurotic edema of uvula. The uvular edema, no uvula shift. No, my dear friend, please look at me, beta. Whenever you get this picture in the exam, this picture, beta, uvula pushed to other side, tonsil pushed medially, trismus, plummy voice is there. There are 2 diagnoses possible, quinsy or parapharyngeal abscess. If there is no neck swelling mentioned, it's quinsy. If the lateral neck swelling mentioned close to angle of mandible, it's parapharyngeal abscess. And most common cause of parapharyngeal abscess is dental infection. If after dental infection, there's chin swelling and trismus, it's Ludwig's angina. Ludwig's angina. Dr. Dhawan, I am not able to decide what is retropharyngeal abscess and what is prevertebral abscess. Let me make it simple for you. Now, please see. Retropharyngeal abscess is a pediatric airway emergency. You have a big abscess on one side, beta. Why? Retropharyngeal space is not continuous, beta. It is divided into 2 halves. There is a midline septum dividing the 2 halves of retropharyngeal space. So this is basically a child of 2 to 3 years. 2 to 3 year old child and child is having big respiratory problem. Why? There is a big swelling in the mouth of the baby and the respiratory difficulty and respiratory stridor. It's a pediatric airway emergency, and you will see cervical spine to be absolutely normal, and there's a big white shadow in front of the vertebra. This is the widening of prevertebral shadow, and the swelling will be on the one side of midline, unilateral swelling. So this is acute retropharyngeal abscess. May I repeat? Acute retropharyngeal abscess is a pediatric airway emergency. 2 to 3 year old child with respiratory distress, inspiratory stridor, very bad situation, and child is about to die. On examination, there is a unilateral bulge on the posterior pharyngeal wall. X-ray shows widening of prevertebral shadow, but cervical spine is normal. And the first priority of management is the airway management. Dr. Dhawan, there's another term called the prevertebral abscess. My dear friend, prevertebral abscess is orthopedic topic. That is due to tuberculosis of cervical spine. In this, you can see chronic picture, adult patient, adult with the TB of cervical spine, and you see some abscess in front of the vertebra, but cervical spine is also gone. And in this case, patient is adult, and patient has got a midline swelling on the posterior pharyngeal wall. Please see, there are two different topics. Once again, acute retropharyngeal abscess is a pediatric disorder, airway emergency. Prevertebral abscess is an adult topic. Prevertebral abscess due to TB or cervical spine. In acute retropharyngeal abscess, the patient is dying with respiratory distress, stridor, drooling of saliva, and X-ray shows widening of the shadow, but vertebra are normal. So treatment is airway management first. But prevertebral abscess is TB or cervical spine, a midline swelling, vertebra in the midline only, and in the posterior pharyngeal wall. And if you do the MRI, you see definite erosion of the vertebral body. In this case, you do the needle aspiration or IND and start anti-tubercular therapy. Question number 23rd, applied anatomy. Enlarged tonsil, unable to swallow, complaining of ear pain. Ear pain. Which nerve is likely? This question, you know it. Very beautiful question. Look at screen. Please see. Guys, please understand. The beautiful question over there. There's vagus nerve is the mother nerve of larynx. Vagus nerve is the mother nerve. RLN, SLN nerve comes from the vagus nerve. Okay? And the same nerve is a branch to ear called Arnold nerve. It's called auricular branch of vagus. Auricular branch of vagus. Okay? So that's why throat pain referred to the ear. Number two. Glossopharyngeal nerve supplies the tonsil. And same nerve gives a branch to the ear called Jacobson's nerve. Jacobson's nerve, which is a tympanic branch of glossopharyngeal nerve. Tympanic branch of glossopharyngeal nerve. So my dear friend, please see, tonsillitis, tonsillectomy lead to earache via Jacobson's nerve, branch of glossopharyngeal nerve. Supraglottic cancer, peripheral sinus cancer lead to earache via the vagus nerve, via Arnold nerve. Temporomandibular joint pain goes to ear through trigeminal nerve. Base tongue cancer pain goes to the ear through glossopharyngeal, glossopharyngeal nerve. Once again, let's revise it. Tonsillitis, tonsillectomy cause earache due to Jacobson's nerve, which is a branch of glossopharyngeal nerve. Supraglottic cancer, peripheral sinus cancer cause earache via 10th nerve through the Arnold nerve, which is auricular branch of vagus nerve. Base tongue cancer cause earache through glossopharyngeal nerve. Again, and temporomandibular joint dental disorder pain going to the ear is through the trigeminal nerve. Trigeminal nerve. Okay. So answer this question, of course, will be tonsil causing Jacobson's nerve. Beautiful question. Now, question number 24. Now, this again a favorite domain. Laryngectomy has been done in this patient, and there is a patient has a history of smoking is there, and laryngocarcinoma underwent a surgery. They ask you to comment what type of surgery has been done in the patient. My defense, of course, you know, is total laryngectomy. Total laryngectomy. Why total laryngectomy? Because after total laryngectomy, we have got permanent tracheostomy in the neck. How I differentiate permanent tracheostomy from the temporary tracheostomy? In temporary tracheostomy, you always have a tube in place. In permanent tracheostomy, you have sutured the edges of trachea to the skin of the neck. So you sutured the edges of trachea to the skin of the neck. My dear friends, they can ask you, what is the name of this? This is TEP device. What is full form? Tracheoesophageal puncture device. Okay. You can ask Dr. Dhawan, partial laryngectomy will not need permanent tracheostomy. No, they don't need permanent tracheostomy. Permanent tracheostomy is only after total laryngectomy. So the three questions, beta. This patient underwent total laryngectomy. This hole is called permanent tracheostomy. And this is TEP device. This is TEP device. Now, TEP device is a star topic, very likely question. There can be different picture. Don't worry, but both are same. TEP, TEP, TEP. Okay, fine. Don't decide too much. What's the example of the most common TEP device is Blom Singer. And number two, which is very useful, is Provokes device nowadays. Bromsinger provokes. Fine. This is the TP device. How you speak it? You keep the thumb on the neck hole to speak. You keep the thumb on the neck hole for some second to speak. You push the air backside. What is this? This is the electrolarynx. This is the electrolarynx. It's a handheld battery operated external vibrator. Handheld battery operated external vibrator. Fine. This is CT asked in your example. T3, T4 go for total laryngectomy, my dear friends. This is the thyroid cartilage. Thyroid cartilage. The thyroid cartilage invasion is indicative of T4. Let's revise. If vocal cord is fixed, T3. If vocal cord is immobile, T3. If pre-epiglottic space, paraglottic space is involved, T3. If thyroid cartilage invaded or external laryngeal extension, T4. T4. Once again, you will never get T1, T2, don't worry. Cord fixed, cord immobile, some space involved, T3. Thyroid cartilage invaded, perichondritis thyroid cartilage, external laryngeal extension, T4. T3, T4 go for the total laryngectomy, which needs permanent tracheostomy. One of the question of INSTD was, which of the following is not a part of the larynx? That's D is the cricoid cartilage. C is the thyroid cartilage. D is the hyoid bone. And A is the epiglottis. Of course, hyoid bone is not a part of the epiglottis. Hyoid bone is not a part of the epiglottis. It is extra laryngeal. Now, guys, don't forget this tube, tracheostomy. It's Portex PVC cuff tracheostomy tube. It is the best tube for ICU patients. Best tube for ICU patients. And, some question, tracheostomy, the best site is second and third tracheal ring. We do high tracheostomy in laryngeal carcinoma, and that is done at first and second ring. Tracheostomy can lead to apnea. Apnea can be due to CO2 washout. CO2 washout. Tracheostomy will lead to collection of air below the skin, which is called surgical emphysema, and that is due to tight skin sutures. Don't apply tight suture after tracheostomy. It can lead to surgical emphysema. That's collection of air below the skin. And if you don't clear the tube every 2 hours, if your tube is blocked due to improper suction, it is a disaster. Remove the tube immediately. Once again, the best tube for tracheostomy for ICU patient in general is the Portex PVC cuff tracheostomy tube. Cuff decreases aspiration. Maxillofacial trauma, don't forget that. Maxillofacial trauma, tracheostomy is indicated. For bronchial toilet, tracheostomy is indicated. For preventing aspiration, tracheostomy is indicated. Most common site is second and third tracheal ring. But in laryngeal carcinoma, we do high tracheostomy at first and second tracheal ring. Tracheostomy can cause apnea due to CO2 washout. Tracheostomy due to surgical emphysema, air below the skin, due to tight skin sutures over there. Okay, fine. The last question of the evening. A singer has undergone thyroid surgery 1 month back. Recovery has been satisfactory, except that she's unable to sing. Unable to sing higher notes. Something loss of quality of voice is there. Which nerve got injured? I hope you remember. There are 4 nerves. At the lower pole of the thyroid gland, we have got the recurrent laryngeal nerve. At the upper pole, we have got the superior laryngeal nerve. My dear friends, please remember this table of the muscles of larynx. The only abductor muscle is the posterior cricoarytenoid. There are 4 adductors, thyroarytenoid, interarytenoid, lateral cricoarytenoid, and cricothyroid. And cricothyroid has 2 functions. Number 1 is adductor, its main tensor also. And tensor gives us quality of voice. Actually, what happens? All muscle are lying inside the larynx except cricothyroid. It's lying outside the larynx. Imagine a story in your mind. Every muscle is doing one function. But cricothyroid is doing 2 functions. It's angry with the larynx. It is sitting outside the larynx to protest against the larynx. So which muscle is outside larynx? Cricothyroid. It demands extra nerve supply, special nerve supply. If I do 2 functions, I'll do 2 functions, but I want extra special dedicated nerve supply. All these muscles, my dear friend, all these muscles are supplied by single nerve, recurrent laryngeal nerve, except cricothyroid, that is supplied by external branch of superior laryngeal nerve, also called external laryngeal nerve. All muscles supplied by single nerve RLN, except cricothyroid, which is supplied by external branch of superior laryngeal nerve, my dear friends. Please look at screen, look at screen. Because vagus is the mother nerve of larynx. 2 branches, RLN, SLN, that's all. SLN two branches, external laryngeal, internal. Internal, if you remember, is the main nerve to prevent aspiration. And ELN supplies the cricothyroid. All other things by R. Cricothyroid is adductor also and tensor also. Tensor also. Now, let me take you here. You and me are doing surgery today together. By chance, we cut both RLN. We cut both RLN, beta. We cut both RLN. Which muscle is still working? Cricothyroid. If all muscles supplied by RLN except cricothyroid. If we both cut RLN both sides, which muscle is working? Cricothyroid. And that is adductor. Unfortunately, adductor. After surgery, both vocal cord come in the midline. Adductor muscle, na? Both caught in the midline forever. Can you breathe like this? No. So right after thyroid surgery, there's an airway emergency. You are not able to breathe. Patient not able to breathe. That is the tracheostomy to be done immediately. But by chance, we cut SLN. SLN. All muscles supplied by RLN except cricothyroid. So cricothyroid is gone. And cricothyroid is adductor also, tensor also. But adductor are four, no problem. Cricothyroid, if you remember this table better, cricothyroid is the main tensor of the vocal cord. My dear friend, all muscle are supplied by RLN except cricothyroid, which is supplied by SLN, external branch. So if SLN is cut, cricothyroid is gone. That's the main tensor, and that gives you quality of voice. So that's why there's a poor quality of voice. Let me tell you one secret. If after thyroid surgery, patient is not able to breathe properly, this RLN injury of both sides. If after third surgery, patient is not able to sing properly, it's SLN injury. S for singer, S for SLN. If after thyroid surgery, patient can't breathe properly, post-operative airway emergency in the operation theater, patient can't be extubated, big problem. Airway problem after thyroid surgery, RLN injury is the problem. Singing is the problem after thyroid surgery, superior laryngeal nerve is there. अगर गाना नहीं गाया जा रहा तो SLN इंजरी, सांस नहीं आ रहा तो RLN इंजरी. So guys, this was I wanted to discuss with you guys couple of things, and I think we are good to go. And before we go with I just want to read a couple of things for you. Just revise it. I know you know it, but I know you know it. Just everybody hear me, revise it. But old diabetic patient with earache, ear discharge, think of malignant otitis externa. School age child, mouth breathing, hearing loss, think of adenoid hypertrophy with glue ear. 50 to 70-year adult with unilateral glue ear, think of nasopharyngeal carcinoma. Chronic false spinning ear discharge with vertigo, think of labyrinthine fistula with unsafe CSO. If there is headache, vomiting, convulsion given over there, think of brain abscess. If there is headache, fever, and edema on the mastoid, think of sigmoid cell thrombosis. If only edema on the mastoid, mastoiditis. Itching in the rainy season, think of fungal infection, otomycosis. Yes, very important question. Autophony. Autophony is a feature of patulous Eustachian tube. The pregnancy is the cause. In pregnancy, P for pregnancy, P for patulous Eustachian tube. Patulum is always open. I told you, Ostman pad of fat in this tube is always closed. If tube is always open, patulous ET, it's used to autophony is the feature. Autophony and the feeling of movement of the tympanic membrane. Fine? Okay. Multiple perforation of the tympanic membrane. Don't forget this one. Moment you see something like this in the exam, there are multiple perforation of the tympanic membrane. Think of tubercular otitis media. Third window phenomenon, superior canal disease. Yes. A young female with bilateral conductive hearing loss. Think of otosclerosis. Young lady, both side hearing loss, otosclerosis. A female patient with something pulsatile in the ear, bleeding in the ear, is glomus question. A female patient with pulsatile tinnitus, bleeding, glomus. Okay. A middle-aged patient with unilateral SNHL, tinnitus, and imbalance, think of acoustic neuroma. Acoustic neuroma is mostly unilateral. Okay, middle-aged patient, single-sided SNHL with the tinnitus and imbalance. Okay, fine. Slap on the ear. Yes, slap on the ear. And after that, the hearing loss, pain, mild bleeding, traumatic perforation, and treatment is conservative. And female patient mostly with episodic vertigo for few seconds on changing head position is BPPV. Okay, fine. BPPV. BPPV. Okay. Before we finish, few doubtful question about INICT people find it. After surgery of the ear, if somebody gets fluctuating hearing loss, think of perilymphatic fistula. Somebody has dislocated stapes during surgery. But if during ear surgery, after ear surgery, there is fluctuating hearing loss and vertigo, etc., tinnitus, etc., think of perilymphatic fistula. Perilymphatic fistula. And the last thing, the tricky INSTT question. A patient present to emergency with acute vertigo with horizontal nystagmus. Slow component is towards the left side. Slow component toward left side means it's a right beating nystagmus. If you remember, nystagmus has two component, slow component and the right and the fast component. Please see, slow and the fast component, slow and fast. Slow component is by virtue of disease. Fast component is the central corrective response. We always take direction from the fast component. So if he says that slow components toward left side, clinically on the notes will be it's a right beating nystagmus. Okay, fine. What's the most likely diagnosis? Medifan, posterior canal BPPV, superior canal BPPV. Guys, this is not acute vertigo condition, brother. These are typically vertigo for few seconds on changing head position only, brother. And it gets all right. Vertigo for few seconds on changing head position. This cannot be like this, brother. Acute vertigo is something indicates something went wrong with the inner ear drastically. BPPV is a positional vertigo for brief few seconds, brother. Okay, fine. Either it's a left hypoactive labyrinth or right hypoactive. What is labyrinth? Inner ear. Okay, fine. Now please see. Guys, in hyperactive labyrinth, like labyrinthitis, viral labyrinthitis, etc., etc. What happened, brother? In that condition, the nystagmus points towards the same side. Same side. Okay? And in hypoactive labyrinth, means suppurative labyrinthitis or dead inner ear type situation, the nystagmus point to the opposite side. So in hyperactive, same side. In hypoactive, opposite side. So please see, in left hypoactive labyrinth, the nystagmus will point towards the opposite side, means the right beating nystagmus. Right beating nystagmus. Are you able to understand that better? Could you relate to this? It's not BPPV for sure. Slow component is given left side. So nystagmus direction is right beating nystagmus. In hypoactive labyrinth, nystagmus points towards the opposite side. So in left hypoactive labyrinth, the nystagmus will be the right beating nystagmus. Right beating nystagmus. Okay, Uche. Anyone, any questions? If you have, please feel free to ask me. Any doubts if you have? Any doubts anyone has? Any doubts? Any question, debatable question, anything in your mind, but that's the link for the Telegram. I would like to hear from you guys that whether the session was helpful for you or not, for INSTD particularly, we should be serving that to you in the last part of preparation. That was the target of creating the RDX series, the rank series. We are doing other subjects also one by one now. You have the schedule on the Instagram, on mine also everywhere. But we'd like to know that what was your learning experience, because that's what we need. We want to add some sense to your preparation, more confidence, more clarity about the confusing. We want to end on deal with the confusing topics actually, not run away from them for you guys. You should know why it is so and how it is so. So, thank you very much, guys. And I must remind you, people preparing for INSTT NEET PG examination, please be fully dedicated. Do not really, take it as just another phase of your life. It's a deciding juncture of your life. Because this will tell to give you the branch also, the college also. So the dedication level should be 100%. You should be not doing, a lot of things. And one of the things is preparation for the exam. You should be only doing one thing at this moment. This is the most critical part of your life. So I hope you understand that you are doing a lot of hard work and you are actually, at least putting your level best to score as many questions correct as possible. Okay. Thank you very much. Thanks a lot. Thanks a lot. Keep studying, keep learning.